Hey, good evening. It's Dr. William. Welcome to my live. Tonight, we're going to be talking about breast augmentation. So this is if you've seen my lives before, it's very similar in the fact that it's a two-night live presentation. So tonight's the first night, and then tomorrow we're going to have the second night. And tonight, it's going to be the whole presentation is focused on breast surgery, cosmetic breast surgery. So we're not talking about breast cancer. So that's reconstructive surgery. So we're talking about cosmetic breast surgery. So tonight we're going to focus on breast augmentation. And I'm going to give you a little bit of background about myself. My name is Carl William Schwartz. It got shortened to Dr. William in Miami because of the difficulty for people saying my name, so I just go by Dr. William. I'm a board-certified plastic surgeon. I grew up in Vancouver. I did my undergraduate there. I did my medical school in London, Ontario, and then I moved across the border to join my wife in Detroit. I did general surgery there. Spent 7 years. All my kids were born there. I also did a couple of years of research in the lab during that time where I got a master's degree in genetics. And then I moved south to warmer climate and did my 3-year plastic surgery training at Duke. And here I am in Miami. So, just going to give you a little outline of the 2-day class. So this is day 1. We're going to be talking about breast augmentation. And tomorrow we're going to be talking about everything else, basically. Breast lift, implants, reduction, tuberous breast, implant exchange, everything there is with cosmetic surgery. The reason why I've split it up this way is because I'm going to be talking about the recovery tonight from a breast augmentation, but that's really very similar to all the recoveries for all the surgery, whether you have a lift with implants or whether you have a breast augmentation. The recovery is about the same. So I'm going to go over all of the recovery as well tonight. And so tomorrow we can just get down to brass tacks and go through all the different problems. So, and the other thing I wanted to bring out is we'll also be asking questions, answering questions on breast augmentation today, and then tomorrow I'll be taking questions on all the other topics. So if you're somebody that wants a breast reduction, for example, this live will still be good for you because you can go through all of the recovery part, but when it comes down to talking specifically about breast reduction, we're going to do that tomorrow. There's a lot to go through. If you've seen this before, I'm very thorough. This is a comprehensive video that is meant for you to learn everything I can possibly tell you, and it's going to be about 4 hours total time, and so it's going to be very comprehensive. If you can stick with it and stay through it, then you're going to get a PDF on the top 10 things that you can do to prevent a capsular contracture. And that's really, you'll see later on in the talk, the most important thing to know before having a breast implant is really about capsular contracture. So I've got this nice PDF, and it goes through all the 10 things that can be done and things that you can do, things that I can do in order to prevent yourself from developing a breast implant capsular contracture. So that, if you stay through, that we'll give you directions on how to download that. Okay, so just a few little topics we're going to talk about today, just to give you an idea. This is a big subject matter, even though we're only speaking of breast augmentation. We're going to talk about selecting the right implant, implant styles, who's a candidate, what is fat grafting, pregnancy and breast augmentation, recovery from breast surgery. We're going to talk about the complications. We're going to talk about capsular contracture, infection, ways to prevent infection, how long implants last, when to change them, things to get before having a breast aug. So a few things that you'll need: long-term results, breast size, shape, where's the incision, where do the implants go, breastfeeding with breast implants, cancer screening. So all of these topics we're going to get through today. And I'm going to start off with a very bold statement that what my kids will call hot take. which is most of what you know about breast augmentation is wrong. Now, obviously, I've never met you. It's a pretty bold statement to make without knowing someone. But I'll tell you why I say this is because over all the years that I've been doing consultations with patients interested in breast augmentation, usually most of the information that they know and think to be correct is actually not true. And it's different for breast augmentation than it's been for anything else, tummy tuck or liposuction or BBL or any of those types of things. There's more misinformation out there about breast augmentation. So we're going to go through and clear these things up. So hopefully after this, you're not going to be under any wrong impressions. So we're going to start out looking at what you're going to be doing before surgery, so how to prepare for your breast augmentation, and then we'll be going, how to recover from your breast augmentation. I'm going to be going through all of this in the same way, and then we'll take a little break and we'll get some time for questions. So if you have any questions about what I'm talking about during the next, say, 20 minutes or 30 minutes, just make a little note and then we'll have some time. We'll kind of break up the live with some questions. So here we go. 3 weeks before surgery, you're going to make arrangements for a caregiver. This is not a hugely demanding job because it's a much shorter period of time to recover from a breast augmentation, but you're still going to need a caregiver. You can't come to surgery without having somebody take care of you. You're going to need somebody to drive you to and from surgery. And they're going to care for you for the first 48 hours, which means they're going to manage your medication, including the right doses, when to take them. You can't really do that type of thing yourself because these are narcotics and they can inhibit your judgment and timing and thinking. So you really want somebody to be managing that for you, helping you just kind of get around the house and being with you. It's just important if you're going to have a surgery, you always have to have somebody with you. And I think when it comes to a breast augmentation, the first 48 hours is sufficient, but make sure you have somebody really dedicated to caring for you. Don't leave this to decide after surgery. You're going to plan your sleeping arrangements. We're going to talk about that a little bit later. One of the misconceptions is that you can't lay on your tummy after having a breast augmentation. The reality is you can. You can sleep any which way you want. We'll talk about that. Constipation is a problem after surgery. I always say sometimes people can have a very easy recovery, otherwise they really don't have much pain, they're very happy, everything's going well, and then the constipation can ruin a good recovery. So a few weeks before surgery, you're going to want to eat a high fiber diet, decrease the amount of meat that you're eating, and it's not a bad idea to add some daily Metamucil to your diet. That will increase your fiber. Remember to consume Metamucil with quite a bit of water. And it's probably a decent idea to pick up some Miralax just to have that on hand in case you run into any issues post-operatively. You're going to want to, so right now we're 3 weeks before surgery, okay? So you're going to want to stop smoking for 3 weeks before and 3 weeks after. It's not a deal breaker for having a breast augmentation. If you're having a facelift or you're having a tummy tuck or you're having a breast lift where we really reorganize and change the blood supply to those areas, smoking is a deal breaker. So if you test positive for nicotine, your surgery will be canceled. But if you have a breast augmentation, that's not the case. We can operate on a smoker because the blood supply to the breast is really being maintained after having a breast augmentation, and so the effects of smoking on constricting those blood vessels is not really very important. You have plenty of blood supply there. But I tell my patients, if you do smoke for any type of surgery, you're going to double your chances of having a problem in terms of the complications and the risks. Marijuana is okay to use. Make sure you're not using it in a nicotine vector. As I mentioned, we do test for nicotine. Marijuana can be helpful. It can relieve anxiety. It can help with nausea. So it's useful. And I don't mind patients using that as long as it's not in something with nicotine. These are the standard labs. I won't go into too much detail, but we usually get standard labs on everyone. Make sure that their blood clot's okay, that their blood counts are okay, their kidneys work, thyroids are fine, and also do a test for pregnancy and an HIV test as well. This is important. These are medications to stop before surgery. So Ozempic, and I just put Ozempic, but all the other medications that are like it for weight loss, those should be stopped 2 weeks prior to surgery because they delay the way the stomach will empty. And that can have food back up in your stomach. And when you have a general anesthetic, you go to sleep, and you lose your gag reflex when you're going to sleep. So now you don't have any way to protect your airway. Anesthesia will have a breathing tube in, but that's not 100% able to stop potential fluid or food contents from going from your stomach into your lungs, which can be totally disastrous. So all those types of medications stop 2 weeks. And all these other medications here, I really only talk about the NSAIDs, which are the non-steroidal anti-inflammatory group. Those are your Aleve and Motrins, Excedrin, all those types of drugs. And the reason we have those stopped is because they can contribute to bleeding. And one of the main complications that we can run into, thankfully it's very rare, but we can, and that is bleeding after surgery. So you don't want to be taking any of those medications that will increase your risk for bleeding after surgery. The oral contraceptives, we recommend stopping them before surgery. They increase your risk of developing a blood clot. The chance of getting a blood clot from a breast augmentation is pretty low. I mean, I've never had a patient develop a blood clot after a breast surgery. I have with patients who have had tummy tucks, but even still, it's you can decrease your risk by stopping your oral contraceptives 2 weeks before and 2 weeks after surgery. Alcohol, I don't like patients to consume alcohol for at least 48 hours prior to their surgery. These are medications that you're going to continue taking. And so, for example, if you have asthma, you're going to want to continue to take your asthma medication. Take it just like you normally do. With all these medications that you're going to continue, you're going to take them exactly as you normally do. Same time of day, same amount, everything else. Don't miss any days. You're going to take it before surgery, day of surgery, day after surgery, exactly like you normally would. You can take it, if you normally take it in the morning, you can take it with a small sip of water prior to your surgery. That's fine. But most of these medications, if you stop taking them, you can have some problems with rebound. So your blood pressure, if you're taking an antihypertensive for blood pressure and you stop it, you can end up having high blood pressure before the surgery or during the surgery, and we don't want to get into any of that. So continue to take those medications, cholesterol, all of those types of things. If you have anxiety, it's particularly important because if you're accustomed to taking an anxiolytic prior to or every day or however you use them, surgery isn't naturally an anxiety-provoking situation. So don't stop taking anxiety medication because your anxiety will kind of go out of control, and we don't want that to happen. We want you nice and calm and relaxed prior to having surgery. We do a drug test on the day of surgery. It's a urine test, you pee into a cup. And as for breast augmentation, which will be different for breast lifts, which we'll talk about tomorrow, but for breast augmentation, nicotine, marijuana, they show up on your drug screen. Doesn't really bother me. But nothing else like amphetamines, cocaine. I'm watching that Griselda show on Netflix, which is awesome. Cocaine. Obviously, if your drug test comes back as pregnant, any benzodiazepines, if you don't have documentation that you normally are taking them, then that would be a reason to cancel the surgery. Okay, So that's a few weeks before surgery. Now, the day before surgery, you're going to just confirm your arrangements with your caregiver, make sure there's no surprises, you know the time when they have to pick you up, what the traffic's like. Don't eat anything 12 hours before surgery. I always get questions about that. There are some shorter time periods in different facilities, different hospitals. For me, we've always used 12 hours. So it's just a safe number. Don't eat or drink anything 12 hours before surgery. Don't stop taking your usual prescriptions. Don't stop taking your blood pressure medication. And then this is the evening before your surgery. When you take a shower, we want you to do is wash your body with Hibiclens. It's a special type of antiseptic soap, and that's been shown to decrease the rate of having an infection. Most people think that when you have an infection after having surgery, really any type of surgery, that it must be coming from the operating room or the surgeon or the instruments or something like that. But most of the time it's coming from the patient's skin. And it makes sense. We all have bacterial bacteria all over us. That's normal. And when you're making an incision, despite us cleaning, it's still, none of these cleaners are 100% effective. It's possible to have some bacteria that are still lingering around, and they can contaminate your implant or give you a wound infection, for example. So it's one of the things that we do to try to prevent infection is have you use Hibiclens the night before your surgery. Really focus on your chest, your underarms. When you have a breast augmentation or really any breast surgery, your arms are out on when you're laying down on the operating room table. And so this area here is all in the operative field. And we want, I usually try to drape off the armpit, but it's still anywhere that's kind of getting close to the operative field. We like to make sure that you're washing out well with Hibiclens. You're also going to take care to really wash your nipple areolar complexes. Women's nipples come in all different shapes and sizes. Some of them are inverted. Some of them have more crevices. So just make sure you do a good job to really get the Hibiclens there and really wash carefully all your breasts, including your nipple areolar complex. Day of surgery, don't wear makeup, deodorant, jewelry, contact lenses, piercing, take all those out. Remove nail polish on each index finger so we can keep track of your oxygenation. Comfortable clothes, shirt open in the front, sweatpants, slip-on shoes. Nothing fancy. This is nothing fancy. It's not very common for patients to throw up after a general anesthetic. It used to be much more common because we used to use a lot more narcotics than we do now during the surgery. But still, it's possible that you can be nauseated or even throw up after surgery in the car ride. So you want to just make sure that you got yourself covered for that. The day of surgery, when you come in before surgery, you're going to have a nasal swab. You're going to do it by yourself. There's a little kit that I use from 3M, which has some povidone iodine in it, and it's incredibly effective at killing the bacteria that's in your nose, including Staph aureus, which is a common bacteria that we find in infections. And so you can also harbor methicillin-resistant Staph aureus, or so-called MRSA. And so we really want you to be very thorough to use the iodine in your nose. I've used it myself. It's not bad. It doesn't smell bad. It doesn't hurt or anything else. And it's kind of has a little bit of thicker viscosity to it, so it's not going to run all down your face. So you just take a little swab, make sure you're very thorough, get into all of the areas, get under the nose, underneath the top part, and make sure you get all of that covered. That's important because, as I mentioned, 30% of patients are colonized with Staph aureus in their nose, and it's been shown that 80% of infections actually come from patients' own nasal bacteria. The other thing that I do to eradicate the bacteria in the nose and focus on MRSA is using Bactroban. This is a prescription, and I have patients use that in both of their nose for 5 days prior to surgery. It's important. The reason why we're doing this is we're trying to prevent you from getting an infection in the implant, and we're also trying to decrease all of the bacteria because there's been some link between bacteria and a capsular contracture. So whatever we can do to decrease that with washing with Hibiclens, using your Bactroban, using the iodine, all of those things will help decrease your chance of developing an infection. It's very low to develop, it's a low chance to develop an infection with breast augmentation. The problem is if it happens to you, it's not really very good because we have to remove the implant and we have to leave the implant out for a few months while your body cleans out all of that bacteria, and then we'll go back in and put the implant in. So it's very awkward and it's upsetting if patients have to have an implant removed because you're walking around with one implant and one flatter chest. So it's important to be compliant, to follow these instructions when you're doing it, because we're all about reducing bacteria and decreasing your chance of an infection. So let's get into a little bit more of the recovery. It's an easy recovery, really, compared to most plastic surgery procedures by far. And everyone has their own recovery time and healing and everything else. But what I'm going to give you here are some good generalizations. And I'll just kind of take you through some of the topics that you may experience during recovery and sort of explain why you have them and what you can do to ameliorate them. So chest tightness, chest discomfort or pressure, it's not, I always say it's more like just heavy pressure on your chest rather than somebody stabbing you with a sharp knife. So it's more of a tightness, a pressure. Sometimes patients describe a difficulty breathing. Some people say, I feel like I can't breathe. They can breathe fine and your lungs are completely expanding, getting oxygen. When patients say that to me, they're never saying it in a way where they're out of breath or can't talk. They're not really short of breath exactly, but they have a sensation. Just because, particularly if the implants are underneath the muscle, then that can exert some pressure. It usually only lasts for about the first 48 hours, and it goes away fairly quickly. That's probably the most common reason why patients will use pain pills after their surgery is to combat that. In terms of work and travel, most patients can go back to work in 3 or 4 days after their surgery, as long as their surgery is not involving any heavy lifting. So, for example, a lot of nurses get breast augmentations and breast surgery, lift everything. And, they have a very physical job because they're moving people from bed to bed and sitting people up in bed. So you don't have to have a laboring type job for your job to even be physical. And so you just have to kind of be careful. Usually the nurses will go on a different duty. They'll have someone else lift for them or help them or whatnot. So it's okay to go back. You have a desk job, 3 to 4 days. That's not a problem. And you can heavy lift, but you can only do that after 6 weeks. 6 weeks is usually our kind of golden number with any type of surgery when you get pretty strong tissue at that point. If you're traveling from out of town, we suggest staying in Miami for 72 hours after surgery. Just because that's an early time when you can rebleed, and we want to keep an eye on you during that time. Again, complications from breast surgery are not very common, but this is an elective procedure. We're dealing with healthy patients. We want to minimize everything we possibly can. So if you're coming from out of town, we want you to stick around for a few days afterwards. If you need any documentation, a letter saying that you're under physician's care, we can provide that. You don't need any documentation to travel. I personally do not provide any FMLA paperwork. It's just too laborious and time consuming and requires a lot of staff to do that, and a lot of my time, and it's really just not possible. So I don't do any of that, and really I don't think anyone needs any FMLA paperwork for breast augmentation because the recovery is so fast. Ice, heat, and massage. So icing your breasts, you don't have to do it, certainly. I personally, if I'm strain a muscle or do something, I'm a big fan of ice. I like it. It provides pain relief, and I think it's very effective. But you have to be careful when you have surgery and a sensation has been changed temporarily to all of those areas. You're on narcotics. We don't want you to put an ice pack directly on your breast. You doze off, you go to sleep, and next thing you know, you've got problems with your nipple or your areola. With not getting good blood supply, or you're getting even ice burns of the skin. So if you want to use ice, I'm okay with it. You don't have to, but just do it for short periods of time, maybe 10, 15 minutes every 4 hours, and just make sure that you're aware of the fact that some of your caregivers involved, and they know, oh, okay, she has ice now, so I'll just keep an eye and give her 10 or 15 minutes. We don't want her to keep that on all night. I prefer no heating pads or any kind of warming devices on the breast. Similar reasons as I just mentioned, and also I think it's just not a good idea in terms of bleeding. What you can do is you can do a gentle massage to your upper pole. So when we're talking about your breast, we kind of picture it as a globe, if you will, and the upper part is your upper pole and the bottom part is your lower pole. And so the upper pole is really where you tend to feel a lot of heaviness after having a implant that's under your muscle. And so sometimes it can feel good just to gently massage that area. So that's totally fine if you want to do that. I think it's great. We're going to be talking about touch later on and how important that is. But in the past, when I started, when I was training, they told us, make sure everyone does all of their massages after having a breast augmentation in order to prevent a capsular contracture. That we know is not true. And today we put the implant in a very precise location and precise pocket. And we don't really want you squeezing or moving or massaging or moving it around. I think it can generate bleeding and change the capsule. So I would not, or change the pocket. So I don't recommend anyone doing any formal massage. If you want to do some gentle massage, that's great. I encourage that because that can help relieve some of that pressure. And it also kind of helps you start to accept your breast implants, which I know it sounds a little weird, but after surgery, people tend to ignore their operative site. So if you get injured on your finger, you kind of protect it and you don't, you guard it. It's natural. With your breast, sometimes patients can become very sort of robotic and stiff, and they don't want anything to happen to their chest. But I think if you touch and you're doing gentle touch and light massage in this area, then it's kind of helping you to overcome that obstacle where you're thinking like, oh, these are foreign objects and they don't belong. It helps you to kind of make them your own and accept them. So I think it's a good idea. You've heard me talk about cleaning and the antibiotics we use in the nose and the iodine. You're going to receive the antibiotics that you won't even know. They're going to be through your intravenous, through your IV, and that happens very close to your surgical time. And that dose of antibiotics is actually the most effective dose of antibiotics that you're going to receive. You will have antibiotics given to you by mouth, oral antibiotics, just like you would normally take, you get at a pharmacy for a urinary tract infection or something, you'll have a prescription for that you'll fill. So you'll have 5 days of antibiotics that I'll have you take, and it's important to take those. You're going to start on the day of surgery, but you don't need to take anything any longer. And just keep in mind that if you were to fall asleep or skip a dose or something happened, you've already received the most important dose during the IV, so that'll give you a little peace of mind. But obviously I'd prefer if you continue to take them as directed on the bottle. Pain pills, everyone gets pain pills. It's a narcotic. I usually prescribe Percocet for postoperative pain. Sometimes patients want a different pain medication, like a Norco, for example. That's fine. You have to keep in mind that you're only going to be using the pain pills for a pretty short period of time. Most people are 24 or 48 hours at the most. And all pain medications to give you constipation, nausea, and vomiting, potential rash. So just keep that in mind when you're taking those. And the best thing to do is to try to switch to Tylenol fairly early on. You just have to be careful that you're not combining the Tylenol with the pain pills, because both of them contain Tylenol and you don't want to be taking too much Tylenol. So just be careful of that. Fever. The fever is for my whole residency and internship and as a medical student. I can't even tell you how many phone calls I've had during call about fever. I mean, thousands. And you really have to understand, even in the hospital, I would get these calls where somebody had just come out of surgery. Let's say they were an earlier case in the day. They got out of surgery at 11 o'clock and in the morning. Then you get a call at 8 o'clock at night. Mr. So-and-so or Mrs. So-and-so has a fever. And it's the same day of surgery. So all that needs to be done at that time is to get up, walk, deep breathe. Deep breathing helps to open up your lungs, and that's where the fever is coming from. So it's totally normal within the first 48 hours after surgery to have a fever. Now, some patients worry like, hey, I didn't have a fever. Is everything okay? And I get that, but it is normal. You don't have to have a fever, but if you do, it's normal from having a general anesthetic. Your little airways in your lungs collapse, and that causes your body to kind of kick in and start generating heat. So if you get a fever, don't be alarmed. Walk, deep breathe. You can cough a little bit. That'll open up all those little air sacs, and that'll help you. Now, in the first 48 hours, no problem. If it's after 48 hours, and you have a fever, which we classify as anything over 101.5 degrees Fahrenheit, that's important. That's when you're going to want to call your surgeon. So first 48 hours you have fever, don't worry about it. After that 48 hours and you develop a fever, that's when you're going to want to call your surgeon. Speaking of when to call your surgeon, this is important for you to know this. At what point should I call my surgeon after surgery? So it's important to know. We like to know as surgeons. If we have to accept complications, it's part of operating. It's an old expression that says, if you're a surgeon and you don't have any complications, it means you're not doing enough surgery. So if you do one surgery a month, then yeah, you're probably not going to have many complications. But if you're like any other person in terms of operating a normal amount of patients, then the complications will come up. But it's important. We want to identify the complications, and we want to treat them, and we want to do that promptly. And so if you're experiencing a large increase, for example, you go home from surgery on Tuesday, and Wednesday during lunchtime, you notice that one side of your chest is twice as big as the other side. That's not just swelling, that's most likely you have a hematoma. There's been some bleeding, and you need to call your surgeon. So don't sit on that, don't wait. you're going to want to notify your surgeon right away. That's an important thing to be notified of, because that requires surgery. We usually will go back in, open up the incision, remove the implant, wash the implant, see what's bleeding. Usually we don't see anything that's bleeding. Usually it's stopped by then, but you still want to get rid of the blood clot. We call that a hematoma. We want to evacuate the hematoma, because having a hematoma after a breast augmentation increases your risk of developing a capsular contracture. So we want to get on that as soon as we know about it. You'd also want to call your surgeon if you're developing any redness of or around your incisions. That's important. That can be a harbinger of infection. It gets a little bit tricky because typically after surgery, incisions are red because they're inflamed. So inflammation can cause redness that is not infection. And it can be a little bit difficult for a patient to figure out on their own the difference between, is this just redness from normal, just having an incision, my body's reaction to heal it is through inflammation, or is this redness an infection? And so it's important if you see that and you're concerned about it, call your surgeon. If it is something that is in the skin, it's a bacterial infection in the skin, then we can treat that with antibiotics. And what we want to do is we want to recognize and treat it early, because we don't want that to just brew and then enter into your breast pocket. As long as it's confined to your skin, we can treat it easily with oral antibiotics. You don't need to be admitted to the hospital, and we can treat it early. Then it usually just resolves with oral antibiotics. So that's really what we're trying to prevent, is that infection from going from your skin in deeper into the breast pocket. If you have any types of shortness of breath, urinary frequency of burning like a urinary tract infection, a pretty persistent rash, then those are important reasons to call. Any drainage or fluid, foul smelling fluid coming from your incisions, obviously, or any bleeding that results, that sort of actively bleeding, you'd want to let your surgeon know. If you notice a little spot and you put pressure on it and it never appears again, then that's a different story. When to shower, and don't worry, we're going to be getting to the breast augmentation and the implants and all that stuff. I want to just make this very comprehensive so that when patients are going to have breast augmentation or really any breast surgery, they just know some of the things that they need to do in terms of preparing recovery. So just bear with me. So when to shower after surgery, I let my patient, and again, these are my recommendations, what I do with my patients. Your surgeon may be different. I have my patients take a shower 24 hours after surgery. I don't want any baths, hot tubs, pools, any of that water for 6 weeks until everything is perfectly closed and healed. Particularly now in the oceans, there's been changes with the oceans where bacterial, it's increased some of the bacteria that can cause pretty serious skin infections and necrotizing fasciitis. So you don't want to be going in any type of body of water until everything is good. So I just say 6 weeks, just avoid doing that. Everyone gets put in an OG Easy Bra. I'll talk about that later. But you're going to remove your OG Easy Bra that was placed during the surgery. You're going to wake up, you're going to have a bra on. It's really a dressing and a bra all at one. And then there's steri strips that are underneath that bra that go along the incision. So you're going to keep those steri strips on. Don't mess with them. Take a shower. Don't sit there and just soak yourself in the water, but take a shower, wash like you would normally do, and you can get your breasts, you can have the water run over them, and then afterwards just pat everything dry so that the little steri strips will get dry. But just kind of wash as you normally do. At that point, you don't need any special soap. Hydrogen peroxide and alcohol, don't use them. Don't use either one. I could go on and talk about half an hour about this, but just take my word, don't use them. I don't like any of these either. So your Polysporin, your Neosporin, These can actually really create, I've seen many times patients that have used Neosporin on their incisions, and then what happens is they'll develop a contact dermatitis, which is really pretty frequent, the number of people in the population that develop a contact dermatitis, and that can really lead to worse scarring and pain and a secondary infection. You can actually get a bacterial infection. So sometimes people are putting these things on their incisions to try to decrease the chance of getting an infection, and they're actually increasing their risk of getting an infection if they develop one of these contact dermatitises. So I don't recommend any of these products, and I don't use them for routine breast augmentation or any breast surgery. How to sleep after surgery. So this is something that usually raises some eyebrows. But you can sleep any which way you would like after having a breast augmentation surgery. You can sleep on your tummy, sides, front, back, however you want to do. The most important thing is that you get good sleep. Sleep is very important while your body is healing and recovering. And you're going to be tired. The medications make you tired. Anesthesia makes you tired. Narcotics make you tired. Your body's kind of been revved up a little bit. You're going to be tired. Get into a position that's comfortable so you can get the sleep that you need in order to recover. You're not going to do any damage by sleeping on your newly augmented breasts. If you're concerned about it or for comfort reasons, you can always put a blanket on top of your, sort of under your neck here, and then under your breast to kind of take a little bit of pressure off if you lay on your tummy, or put a pillow. That's fine. If you want to sleep in a recliner, a lot of people do. I'm just saying you don't have to. And I'm trying to get rid of some of these stereotypes and misinformation that's out there about breast augmentation, and this is one of them. So just get a good sleep and figure out how you want to do that and do it. In terms of what to eat, your diet after breast surgery, you're going to eat just a clean diet, meaning it's low in processed foods and low in fried foods. I wouldn't eat any fried foods. You're going to want it high in fiber. As I mentioned, a lot of the medications, including the anesthesia, can give you problems with constipation. All of them slow your gut down, and when you do that, you can get constipated. So eat high fiber, drink a liter of fluid a day. You don't need to drink a gallon of water. As you see these people walking around with these big Stanley cups. Or you don't need to force yourself to drink. If you're hungry, eat. If you're thirsty, drink. If you're not that hungry for the first day, it's okay. If you want to eat a few little crackers, that's fine. You don't need to force yourself to eat. But if you do, just select the correct foods. But there's no special diet that you have to be on. Over-the-counter pain medications after surgery, we talked about those, Aleve, but I just want to mention again because it's very important not to take any Aleve, Motrin, ibuprofen, all of those drugs. For those of you in the South, don't take any Goodies powder. God, when I moved to North Carolina from Michigan, everyone kept telling me, take some Goodies powder. Yeah, I got a headache. Take Goodies powder. I mean, anything was Goodies powder, but it contains things in it that will make you bleed. So don't do any of that. Don't take any herbal supplements because all of those things can cause bleeding. What you can take is you can take Tylenol, but as I mentioned to you earlier, if you're taking it at the same time you're taking the narcotics, make sure that you're keeping track of how much Tylenol you're getting. So if you're taking 2 500 milligrams extra strength Tylenol, that's 1,000 milligrams, it's 1 gram. And in your Percocet, there may be 650 milligrams. So you don't want to be taking 1,650 milligrams of Tylenol and doing that every 4 hours, or you'll go into liver failure. So just be careful. Realize Percocet has Tylenol and Tylenol has Tylenol, the same things. So you just can't double up on them. You have to do it one at a time. Okay, what bra to wear after surgery? So I have everybody stay in the OG Easy Bra. There's nothing like, I'm not going to make this all about the OG bra, but it's totally different. It's the only sterile bra on the market. It's more than a bra, it's a dressing as well. So that goes directly, it's absorbent, it's sterile, you use it one time. So I put it on you in the operating room, and then the next day you take that one off, throw it away, you put a new one on. We sell them in groups of 5 through OG Recovery, which is my recovery company, because I'm going crazy about recovery the last couple of years, just because I think there's so much misinformation, and I just see so many people repeating the same mistakes all the time. It's like golf. You go out to the driving range and you're listening to this guy and this guy, they're saying the same thing, and then you get a lesson with the golf pro and he's like, no, that's all wrong. So all of these kind of things become perpetuated, and then people believe, oh, that's the way you have to do it, when it can be totally wrong. So I like someone to be in the OG bra immediately after surgery. I put it on you when you're asleep. You wear it every day for the first 5 days, take it off, put a new one on. It's nice and clean, sterile, goes right directly on the incisions. And then after those 5 days, you can transition to a regular post-operative surgical bra, and you'll wear that for 6 weeks after surgery. You can cheat when you start getting out to like 3-4 weeks. You don't have to wear that bra to a dinner function where you're wearing a clothes that's not going to be compatible with that type of bra. That's fine. You can take it off for a few hours, enjoy the freedom, but don't take that as, don't interpret that you can then kind of just really start doing whatever you want. It's really important to wear a bra for 6 weeks. If you think about it, you're going to have your implants for a very long time. It's worth spending that time early on during your recovery to make sure that everything is positioned where we want them. Most often bleeding happens within the first 48 hours. There are some people that can present and come to the office later, a month out. I had a receptionist one time, a long time ago, really delightful person, and she went off-roading in a vehicle very shortly, well, maybe a week after having her breast augmentation, and she developed some bleeding. Now, thankfully, it stopped. We didn't have to do anything. There was no consequence. But if you're going to, well, number one, I wouldn't recommend going off-roading. But number two is keep your surgical bra on, because that's going to stabilize your breasts and your implants as that tissue heals. So you can take it off a little, cheat a little bit after a few weeks, but don't turn that into a habit, because we still want you in that bra. And then after 6 weeks, you can wear any bra that you like. And when I tell patients that they can wear an underwire bra, sometimes they're really shocked, but it's totally fine. Dressing and stitches, these are pretty easy. All the sutures dissolve, so there's nothing you have to worry about. They all dissolve on their own. Sometimes you can feel like a little piece of them at the corner where I tie the knot. Don't worry about that. That's going to dissolve as well. The steri strips are going to come off on their own. And if they start to peel up, you can just trim them. But don't replace them, or don't put any tape or any Band-Aids or any of those types of things. I know it makes sense. Oh, I had this strip on, now it's come up. Or it's come off, I should do something to repair it or put some. Don't. Just leave it open. That was a sterile steri strip that was placed at your time of surgery. I don't want you to then place a Band-Aid later on to cover it, anything like that. If they come off, they come off. Leave them on as long as you can, as long as they're clean. Then leave them on, and trim them if the little edges start to roll up. If they're dirty and they're not really adherent, they're not really do much, then by all means take them off. But I usually tell patients to leave them on for as long as they can. Because to me, in my mind, I think it's acting like a cast, sort of when we immobilize an arm, for example, after an arm fracture, that is immobilizing those two bone ends so that they can heal together. And the steri strip is designed to take tension off of the wound, so it's kind of acting like that little cast on the incision, and I think you get a better scar if you can leave them on. Typical follow-up schedule, and again, this is kind of my follow-up routine, but every surgeon will be different. Usually have the patient come back the next day after surgery. Have surgery on Monday, come back to the office Tuesday. Make sure we're just spotting for problems is really all we're doing at that point. That's not a check like, oh, do you like your size, this or that. That we're just looking for problems, making sure that everything is okay. And the main thing we're looking for is hematoma, which is bleeding. Again, less than 1%, but we want to spot it early. And then I'll have patients come back at 6 weeks, sort of as a clearance, like, yeah, everything's good, incisions are good, it's clear, you're clear to work out, do all your normal activity, and then usually a year to look at the results. It takes a long time for the body to heal, and so it's pretty typical for plastic surgeons that will give the body a year to heal, tissue to soften, and then take a look at your result. Scar care, you really have to think of it. Scar care, the way your incision looks depends not only on how the incision is made, how the incision is closed together with sutures, how it's cared for afterwards with the sterile dressing, the Steri-strips, but it also depends strongly on how you treat the scar and the time and effort you put into a scar. And if you really don't put in the time and effort, your scar will not be as good as someone else who does. There's no question about that. Typically, the way wounds heal is we make the incision at 3 weeks. They're raised, they're red, they're lumpy. That's called the healing ridge. And then at that time, the 3-week mark after surgery is when I recommend patients start scar care. I have a very simple scar system. It's called the OG scar system. It's only 2 steps, which makes it very easy. There's a scar gel. It comes on a very specifically designed bottle that has a roller on the head, and it has on the bottom it has a button to turn vibration on, and it was designed specifically that way because the best way, the most effective way to use a scar gel is to actually massage. And so you use the ball to massage. You do that twice a day, 2 minutes for 1 year. And then at night, the second part of the system is a silicone gel, medical grade scar strip, and you're going to wear that on your incisions. So it's a simple thing to do, massage and wear silicone at night. You have to do it consistently every day, and you have to do it for 12 months. And people usually utter like a little gasp when I say 12 months, but it takes that long for the body to heal, and you can impact your scar during those whole 12 months. So just think, if you want a good scar, which everyone should, which I want, you're going to have to put the work in. But I've tried to simplify it into a very easy 2-step system so you can be compliant, do it every day for 12 months. Sun exposure, we tell everyone to protect your scars from direct sunlight and wear sunscreen over SPF 35 for the first 12 months. That's a party line. Does anyone do this? I doubt it. I've seen scars on patients that are very well tanned and they end up having very good scars. I'm not encouraging you to go in a tanning booth, of course, but we've all got to live and enjoy our lives, so do with this as you may. Your breast skin, sometimes after you have a breast augmentation, your nipples, your areola, the skin around your breast, it can be kind of shiny. And that's as the skin is kind of a little bit stressed and it's accommodating to the implants. It will go away with time. There's no treatment. There's nothing you have to do. You may see veins more prominently after a breast augmentation. That's not going to really change. If some women have fairly veiny breasts, and you can see it before surgery, you can see it after surgery, that's really not going to change. Sensation. So this is an important subject. There's kind of 2 sensations we're talking about. One sensation is obviously with the nipple and the surrounding areola, primarily the nipple. But the other sensation that where you can have issues is just in general with the skin around your breast. And that you can go from either decreased sensation of your, let's say, of your nipple, or hyper sensation, and meaning it just, anything touches your nipple, just your shirt against your nipple will kind of be like sandpaper. And we don't want to have either of those, obviously. So usually sensation will return to your nipple after having a breast augmentation. Some patients can have long-term insensate nipples. It's possible. It's not particularly common, but it is possible to have. Usually patients will have some decreased sensation, which will then slowly come back over the next year. Sometimes it's faster. Everybody's different. Nipple sensitivity is so variable from patient to patient. Number one, what is their sensitivity? Number two, how important is it for patients? You can have somebody with a very sensitive nipple that is not really that important for her. Others, patients don't have much sensation, and yet it's very important for them. So there's a huge wide variability. But basically, usually you get some decrease in your nipple sensation, and then that improves gradually over time. That usually most patients can tolerate that, and they understand that, and they feel their sensation coming back, so it's usually not too much of an issue. But what can really be problematic is this hyperparesthesia, where you have pain on your nipple, and that can really bother someone. And so the best way to stop having that is to actually, number one, prevent it, and number two, continue with that prevention just till you get out a few weeks. And the prevention is totally simple. It's simply touch. And so you're just going to touch around your breast and your nipple and your areola. You can start the exact day of surgery. You can have your partner do it if you want. I think that's actually good because they can feel that you're not so brittle and fragile and they can't touch you. So it sort of helps with a lot of things. And that will really be helpful and prevent you from developing a painful nipple after surgery. If you do develop a painful nipple, then the solution's the same. It's just touch. And so you're just going to touch. We recommend doing it with 6 different items of differing sharpness, and you're going to just treat the skin and around your nipple and areola with those different tactile sensations. Asymmetry. Let me talk about asymmetry, and I'll show you some slides about that a little bit later too. But you know, I've got twins. I've got twin boys, and I was kind of terrified to have twins. I already had an older son, but I was still nervous about having twins. And so naturally you read some books on twins and what to do. And every single book says 100 times, don't compare them, because they're two completely different people. They were born at the same time, but they're two totally different people. So don't compare one to the other. This one's walking faster, this one's speaking, but you know, they're two independent people. They're going to be doing their own things. Your breasts are exactly the same. You have 2 different breasts. It's natural when you have 2 of something to want to compare them, particularly when you have a breast augmentation. You're going to look in the mirror. It's normal. You're going to look at one, you're going to look at the other, and you're going to be, oh, and you're going to see a difference. Every single person has a difference between their 2 breasts. That's normal. There's different variability. There's different degrees at which patients could be asymmetric. And when we really step out of that normal degree of asymmetry is when we try to do things to correct that. We're never 100% successful. We can't ever get anything perfectly symmetrical. But make sure that you're not driving yourself crazy and by looking and noting every difference between the 2. You're also going to have differences in how you heal. So one breast may not give you any problems, and one breast can give you more pain for longer. One nipple can be totally normal sensation, the other one can be hyperparesthetic, or it can be more numb. They're completely different. Treat them as different. Recognize that you had the same operation on two different breasts, and they may respond differently. Sometimes, and the other thing to talk about asymmetry is there are so many factors that go into what can be an asymmetrical breast. So you can have a different nipple position on your chest. So we always measure from the sternal notch, which is right here, down to the nipple, and we make those measurements. And I've done that for years on many patients, and they're usually close, but they're not very often exactly down to a millimeter, the exact same distance. So you can have some nipple asymmetry. You can have difference in the shape or size of your areola. You can have some differences in the size of the nipples. You can have differences in how the breasts sit on the chest wall. So one can be a little bit further, one can be a little bit angled, one can be a little bit higher. So anything you can think of in terms of what may make your breasts asymmetric, it's possible. And then you have to realize that your breasts are just fat and breast gland that are sitting on top of your chest. So your chest can also have a tremendous amount of asymmetry from one side to the other. So you can have one chest wall. So if we divide the chest in two, like a skeleton, say, and just look at the bone, look at the ribs and the sternum, there's nobody's just perfectly flat and each side is just identical. There's always a little bit of difference between the two. And you can have one chest that's coming back a little bit, while that breast, if it's sitting on a chest that's a little bit lower, then it's not going to project as well probably. Unless it's a bigger breast, then it may project more. So not only is there asymmetry just between all of the things to do with your breast, there's asymmetry with where your breasts are sitting. So when you put all of those things together, there's many factors, and they multiply and can contribute one to the other. That's why it's impossible to be symmetric. I try to point those out to patients prior to surgery. Most of the time, patients don't know. Why don't they know? It's not because they're not observant or they haven't looked at their breasts. They don't notice it because it's normal. So if you all of our human eyes are accustomed to looking at things that are asymmetric, because all humans are asymmetric. If it starts to go outside the normal variance of asymmetry, yeah, we start to say like, oh, looks that person's ear is a lot lower. But in regular everyday stuff, you notice we don't notice it. So I pointed out before surgery, patients won't have noticed it, but I do so that patients are aware of it. So after surgery, if we're not having the exact same projection because one chest wall is depressed, or sometimes you can even have this where your chest and one of your chest wall is bent a little bit more, and your breast will be sitting away from the middle of your chest. That's possible too. So anyway, we do as best we can to make everything as symmetrical as we can, knowing we can't be symmetrical. This is just a little example here of somebody who has two different breast heights. So you'll see that when I'm pointing there in the right slide with my left finger, my left index finger, you can see how her right breast is higher up on her chest. Now, they're usually, if it's less than a centimeter, I don't do anything about it. I'm not trying to lower the fold of the higher breast to try to get them even. If we go beyond a centimeter, I do it, because beyond a centimeter starts to look a little bit more obvious, and then I'll lower the fold. The reason I don't do it less than a centimeter is because anything you do in surgery will have consequences and can have problems. So I can lower the fold. I do it probably every day. So I can lower the fold, but whenever you do something and you're changing the way nature has built it, you can have a problem. That fold can can end up going lower than you want, or it could be a little bit higher than you want. So while we do it on the right circumstance, I don't just do it willy-nilly to try to get something that's normal asymmetry, not trying to get that into that perfectly symmetrical, because you could end up have problems that outweigh the benefits. So but this really points out a couple of things. Not only are her breasts positioned on the chest wall at different heights. So if you look at her right breast, which is on the left side of the screen, it's on the same side you guys are looking at. So if you look at her right breast, so on the left side of the screen, you'll see it says short. So her nipple to the fold, that's a short distance compared to the other side, which is longer. And so not only is the breast positioned a little bit differently, but she's also got a very short, inferior pole, that distance. So that would be somebody who I would say, okay, and you could see where I've drawn to lower the fold down to the same level as the other side. I'll say, okay, I'm going to try to lower that fold to change that. This is an example here of just what we were talking about in a patient on the side with that fold. So here you can see she's got some asymmetry here with her right breast being higher, and then I did lower the fold, and you can see that fold position after her surgery, where now her breasts are more symmetrical. Again, only really do it if I think after surgery she's going to look like that, and I want her to look much more symmetrical. If it's just a tiny bit, it's really not worth doing, because you can create problems that are not worth creating. Rice Krispies. So why the hell would I write Rice Krispies here? Well, as your pocket is created, and we're opening up, and you'll see a slide later, but as we're opening up the pocket and we're putting the implant in, we close the pocket, there's obviously air that has entered that pocket, and your body will reabsorb that air over time. It usually just takes a few days, but you can feel, sometimes patients will notice this kind of sensation of Rice Krispies when they're touching their skin, and that's just the air that's there that's being absorbed. It's not harmful or bad, and it'll go away. If you have Rice Krispies and you're short of breath, that's a totally different problem. So, okay. Now, we're going to talk about the capsule a little bit here, because capsule is something that's very important to understand about breast augmentation, and really not just about breast augmentation, but any implants in general. It's important to understand about the capsule. And if I think back, if you saw when I said everything you know about breast augmentation is wrong, well, what I found is people will have a lot of misconceptions about breast surgery, and sometimes be worried about things that really you just don't need to worry about, and then they won't know anything about capsular contracture. And in my mind, if I was going down in an elevator with you, and you're like, hey, what's the most important thing to know about having a breast augmentation? I mean, I assume you probably would have figured I would have a plastic surgeon, not just ask a total stranger about breast augmentation. Cue the laughs. But so people will, if you're riding down the elevator, hey, what do you need to know about breast augmentation? I would say you need to know about capsular contracture. I'll walk out the elevator, have a great day. So it's important, and yet there's a lot of focus on all these other things that are myths and not correct, and misinformation, and then not discussing capsular contracture, which in my mind is the most important thing that you should understand. So I'm going to talk a little bit about a capsular contracture, and what that really is, what it means, what it looks like, and how do we treat it. So with every single breast implant that gets put in, whether you're having a lift or anything, doesn't matter. Any breast implant that goes inside the body, your body forms a capsule around the implant. It's a soft capsule. People call it scar tissue. It's a little bit different than scar tissue, but It is just a very soft, thin film that goes around the implant. That's normal. 100% of the people have it. If I were to take this pen and implant it into my soft tissue here, then we came back a month later, you'd open it up, even shorter. You'd open it up and we would see, oh, here's the pen. And then there would be a glistening white thin capsule around that. Women that have chemotherapy, when we were interns, we always used to take out these ports on patients, and they would be placed here, or pacemakers, for example, and they could put it in a little pocket on the subcutaneous tissue. They all get a capsule. So a capsule is how your body responds to a foreign body. This, if I put it in, would be a foreign body. A breast implant that goes in your body is a foreign body. Your body has no idea, that doesn't know the difference between this and this. So your body's like, oh, foreign body, I'm gonna make a capsule. So everyone gets a capsule. It's really important to understand it. Nothing can be done to prevent the capsule. That's the way it is. That's how your body heals. That's it. Now, most of the capsules remain soft and they're not an issue. You don't know they're there. If I didn't tell you, you didn't read it somewhere, you don't even know. But in about 3 or 4% of patients, they can go on to develop something called capsular contracture. And that's what I'm talking about. When you hear people talking about a capsular contracture, or sometimes people just say, oh, they have a capsule. Well, everyone has a capsule, but if you have a firm capsule, that capsule, which goes around the implant, can then also squeeze and contract. And it can really squeeze and deform the shape of the implant. It can also ride up your chest with the capsular contracture. So that's what we're talking about when you hear the term capsule thrown about. Everyone has one. Not everyone gets a capsular contracture. Most people do not. There's nothing harmful about a capsular contracture. It becomes hard. Sometimes it can hurt. Most of the time it doesn't. But it may bother you, or it may change the appearance of your breast that you don't like. And in that case, what we do is we go in, we remove the implant, we remove the capsule, we put a new implant in. It's not harmful to you. The capsule doesn't bother you. If you have a capsular contracture, just stay in contact with your surgeon and be evaluated, but it's most likely nothing needs to be done unless you want something done because it's bothering you. Okay, twinges or pains in your breast. So these are, sometimes we call them little zingers or twinges. This is from nerve regeneration. You can get it everywhere you have surgery. When you cut through the skin, you cut the cutaneous nerves, and it can, when they regenerate, they can cause pain. They go away. They can come out of the blue sometimes, even, a month, a year later, you can experience them. Nothing to worry about. This is the same kind of thing I was talking about. If you have a very sensitive nipple, the hyperparesthesia, then you just do the same program. It's a touch. We recommend 6 different tactile feelings. So you do something small. I recommend taking a Q-tip. You can use the blunt tip to be soft, and you can break it in half, and the half part is a little bit sharper. Don't obviously cut your skin with it, but you can provide a different sensation, and that'll help with those little twinges. They will go away. Itching, super common after surgery, really any surgery, but medications can contribute to itching, as well as your body's secretion of histamine, which is normal in the wound healing environment to have a lot of histamine, and that can cause you to have itching. There's really no good treatment. Sometimes patients will ask me, this itching is driving me crazy. What can I do? There's really nothing you can do. It'll just pass with time. In the past, we used some medications, but they're really not effective. So I would just grin and bear it and try not to scratch the areas or scratch them as little as possible. But I've had surgery myself. I can remember when I had that thing taken off the back of my head, and I mean, I just could not stop scratching. It was just driving me insane. But it goes away after a couple of days. It's normal, nothing bad. A rash. So rashes are fairly common after surgery, and it doesn't necessarily mean you're having an allergic reaction. So if you look, for example, there's a lot of people that say that they're allergic to penicillin when they're really not allergic to penicillin. And I was one of these people. I remember I had knee surgery when I was in my 20s, and they said, "Do you have any allergies?" I'm like, "Oh, I'm allergic to penicillin." The nurse was like, "What, did you get a little rash around your balls when you were a kid?" And I was like, "Gee, that's kind of bold." And I was like, "Well, yeah, that's what my mom told me. I don't remember." And so then what happens is people say like, "Oh, well, that's an allergic reaction. You can't take penicillin." Really, that's not an allergic reaction. It's a reaction to the medication, but it's not what we consider an allergic reaction, which would be truly more like hypotension, low blood pressure, or having shortness of breath, tongue swelling. Those types of things are a true allergic reaction. If you have a rash, it could be caused by a lot of things. You've got a lot of different drugs you never had before, and they can produce a rash. If it's really persistent and you're on day 3 of your antibiotics, I usually just tell patients, just stop your antibiotics. You already had the most important dose during the operation, and it's just giving you a rash. Stop, usually clears up on its own. If it gets a little bit like more of a rash, then we can start using things like Benadryl, histamine blockers, cortisone cream. All that stuff is over the counter. But if your rash really starts getting more than what you think is kind of a typical drug rash, or you stop the drug and it goes away in 48 hours, and it doesn't go away in 48 hours, and it's getting worse, then you should call your surgeon, because there's other things that we can prescribe that can help with that. Okay, and one other thing too is, we were talking about inflammation versus an infection, and sometimes it's hard to tell the difference. Well, the same thing with a rash, and sometimes people can think they have an infection. The one of the things to look at to help determine whether it's a rash versus infection is to look at the time course after surgery. So rashes typically happen early, so 3 or 4 days after surgery, and an infection typically happens more like 30 days after surgery. So rashes are usually patchy, they're kind of everywhere. Infection is limited to the operative site, and infections tend to happen later. The rashes happen earlier. Okay, activity. We want you to walk on your day of surgery. Shouldn't be a problem after having a breast surgery. That's, again, the blood clots are low chance of getting it, but we want to get that as low as possible. So walking helps with your lungs, helps with you moving your bowels. I think I'm getting older, so I'm like fixated on constipation today. So it'll help prevent blood clot, and it'll just overall speed your recovery. It's a silly expression, but the faster you recover, meaning if you can get up moving, the sooner you do that, the sooner you're going to kind of be on your way. So don't make the mistake of going home and just lounging around and as if you have the flu. You don't have to be up going to the gym and running around, but being active frequently, short walks around your house or apartment, and just kind of getting yourself moving is very beneficial for a variety of reasons. You're going to kind of slowly increase your activity. I let my patients do gentle activity at 3 weeks, as long as they're wearing a very supportive bra. Sometimes patients will wear their post-surgical bra, and then they'll also wear a jog bra or sports bra on top of that to give them a little bit more support. You don't really have to wear 2 bras, as long as you're wearing something that is going to support your breast when you're being active. We don't want a lot of bouncing movement of the implant, and so just using something supportive is sufficient. And you can start to do treadmill and and some light exercise, ride the bike at 3 weeks, and then you kind of just work your way up to the 6-week mark. At 6 weeks, you can do whatever you like. I have no limitations. If you have breast augmentation, 6 weeks, you can travel anywhere, exercise, anything. You can do anything you want. 6 weeks, no problem, no restrictions. Let's talk about the arms for a moment. Using your arms. Right from the first day of surgery, you're going to be able to raise your arms above your head. I know, sounds like I just totally went to crazy town. No, you can do this, and that's something that people tell you not to do. But you can develop what's called frozen shoulder by not using your arm. When I heard about frozen shoulder, I can still remember Dr. Clara Klein, when I did my, I loved her. When I did my family medicine rotation with her, she had a patient came in and she, the man couldn't move his arm. And she asked me, well, what is your diagnosis? And I'm like, I have no idea. I thought it was maybe some nerve impingement affecting the nerves to the deltoid or to the rotator cuff or something. No, none of that. She said it's frozen shoulder. I had to go look it up and read about it. I didn't know what that was, but it's a real entity, and I have seen it in patients after breast surgery where you don't move your arms and you can develop it's just the capsule that goes around your shoulder. It can develop what's called a capsular adhesivitis or adhesive something. So it gets sticky and it doesn't move, and then you need physical therapy. We don't want you to have that after having a breast augmentation. So use your arms, you wash your hair, do the things you normally do. Don't walk around like a robot. Sex, after a couple weeks, if you feel comfortable, then no problem. Just obviously, use your judgment. Driving, most people can drive their car fairly quickly. 3 or 4 days after surgery, they can be driving by themselves, but you have to meet 2 criteria. You have to be off all narcotics. You cannot have you driving on narcotics. And number 2, you have to have good range of motion of your arms so that you're able to adequately perform any defensive maneuver that you would have to. So you're safe behind the wheel. But that can happen fairly quickly. Animation is something, if you go on YouTube and you type in, don't do it now, but if you type in, I don't know, woman bouncing breasts, you'll see videos almost like party tricks where people or patients are bouncing their breasts or moving their breasts. And we don't see as much of that anymore because we deal with the pec muscle a little bit different. I'll talk about that later. But animation is when you contract your chest muscle that your implant in your breast will move. It's because the implant is underneath the muscle and the muscle can pick it up. We now do things differently, so we release the muscle a little bit more. I release my muscle a lot to try to prevent having animation, because it can be really disconcerting for patients if they're playing tennis or they're weightlifting or exercising or any of these types of things, and they're contracting their chest muscle and their implant is moving. It can kind of be noticeable. So you don't get that if you put the implant underneath the gland. You only get animation if you put the implant under the muscle. So it doesn't mean something's wrong. It just means that the implant is under the muscle. In fact, when somebody comes back to, let's say somebody comes to see me and they have implants and I didn't do their surgery, I don't have any operative reports, I'll have them push on my hands to contract their pec muscle, and I'll look very carefully to see if I can see the implant moving at all. And that will tell me the location of their implant if I don't have any operative report and I'm planning to go back and to do something. As I mentioned, if implants are under the gland, animation is not even an issue. And animation is not as bad as it used to be. We used to have patients with almost everyone because we didn't divide the pec muscle a lot. We left a fair amount of it still intact, and that was enough to really still allow that implant to move. So it's much less now, but it's still possible to get it if you have your implants under your muscle. Okay, let's take a 15 minutes, let's say, 10 minutes even, to answer some questions. I'll take some questions that you have now. And then we're going to move on and we're going to talk about advice that your mom may have for you. You know, as a parent, sometimes we always look at our children, even adult children. You know, they're like our little babies still. So mothers are always free going with the advice. So let's look here. Let me ask a few questions. I'd prefer if they were on breast augmentation. I'm going to stay on that topic. And the lifting and reduction, all of that type of thing, I'm going to be talking about tomorrow. As you can see, there's a huge amount of material to get through. So I'm breaking it up into 2 nights. May even have to do 3. In order to cover everything. So let's just talk about the breast augmentations. Which vitamins? Sweet Marley's asking me for vitamins. I don't recommend any vitamins to take. When starting, Annalil says, when starting massage, you really don't have to do any formal massage of your breast. That's that old thinking where you had to massage your breast to get rid of the capsule, to prevent the capsular contracture. We don't want you doing that anymore. You can touch to help with nipple sensitivity, and you can touch to help with some of the pressure, but I don't advise anyone to massage breast implants. Can I do a lift through the nipple? Amanda, we're going to talk about that tomorrow. It's a much longer answer than I can answer here. I got to show you pictures and things like that. Okay. Buffy Geek says, why wouldn't they remove both implants and then reinsert both? I'm assuming you're talking if an infection. If you don't have an infection in one side and everything's healed and everything's good, then we don't want to rock the boat. We don't want to remove that implant and then potentially have a problem with an infection on the second round. Sometimes patients have asked me to do that. I've usually said, listen, why don't we just take out the one that's the problem? We'll let you heal for a week and let's talk about it again. And usually, I don't think I've ever had anyone that asked me to take the other one out. And it's just a case of treating the one that has the problem and not treating the other one and looking for any more problems. We're trying to do all of these operations as safe as we possibly can. Marie Mertens asked me what implant I use. Is this on screen or not?
Yes.
Okay, it is? Okay. So this is what I use. I use Sientra. There you go. That's what I use. I'm not paid by them. I'm not doing any plug for them. I've used a lot of different implants over the years, and I like their implants a lot. They just, for me, they handle really nicely. They feel well. They look well. They have good warranties and good data behind them. So that's what I use. Michelle Atobra, you can just take regular Tylenol. That's totally fine. Just don't take anything that's going to potentially make you bleed. Nancy, we're going to talk about that tomorrow. We're going to talk about lifting your breast. Nature lover, if traveling alone, I mean, it's fine. You really just need that caregiver for the first 48 hours. And then if you feel comfortable and you're not on narcotics, then you're fine to travel by yourself. I don't think that's an issue. I wouldn't go on a nature walk or explore the Galapagos Islands or something, but if you're just talking about traveling out of town, then that's totally fine. Nancy is asking, is 45 cc's a small or big implant? We consider that a big implant. I'm going to be talking about implant sizing here in a little while after we deal with Mama here. Oh, that's a great question, Miss Mind Yours. Why don't you mind yours? You're asking us the questions. All right, Miss Mind Yours. If you come across, I like your question though. If you come across a cyst while doing breast augmentation, do you remove it? I don't. I heard non-cancerous cysts in breasts are common. Yes, they are. I mean, probably everybody has a cyst if you looked hard enough. Cysts are very tiny. They're totally benign. There's a video on somewhere I made about a breast cyst a while ago. We should probably repost that. I think it was on Instagram maybe. It was a couple of years ago probably. Cysts are really common, but you don't need to treat them, and there's no point going through and trying to open up a cyst and get all of those contents and disturb all of that when you're putting an implant in. We're like the Marines. We want to go in quick and out quick, safely, no one gets hurt, and do things exactly, carefully, and properly. So a cyst, you don't need to treat it, so there's no point treating it at all. Jasmine Williams wants to know if I do armpit incisions. I do not. I'm going to be talking about the implant incisions that we use to do breast augmentation here shortly, but I don't do it from the armpit. There's probably only one person in the country that I would go to if I was thinking of having an implant underneath my arm. His name escapes me right now. He's in Texas. But he does a lot, and he's really perfected it. But for everyone else that's done it, there's increased rates of bleeding, increased rates of malposition of the implant. I like to make the incision, we'll talk about this shortly, underneath the breast, because I can anchor down and prevent the bottoming out of the breast. I can return the structures, namely the fascia, back to its normal configuration, and I can pin down the fold so we get a nice sharp crease between the abdomen and the breast, whereas you can't really do all of that if you're going through the armpit. And sometimes I've seen terrible scars in the armpit, even with some contractures that can even limit our movement. It's not common, but it's possible. Everything we do can have a potential complication. So I know you think, oh, I just want to get in the armpit, never going to see a scar, but you do. And you can be the type of person like you're waving goodbye when your in-laws are leaving, you're like, hell yeah, thank goodness, and you're waving, have a safe trip, and then you're showing them your scar. So I don't like it for a lot of those reasons. What causes your incision to be of the crease? Usually that, Tina, is related to having an implant that's pretty big, and it can kind of go down, and you have to get skin from somewhere. So in order to fit the implant in, and it'll take it from your abdomen. So if you start off and you make the incision for the operation in the crease of the breast, and then you put in a really big implant, that will have to recruit the skin from your abdomen, and that will cause your incision to be above the crease. And that's another reason why I like to make my incision in the crease, is because I can then anchor that incision to keep it in that location of where I made it. Years gone by, people used to tell us, okay, here's where you want your incision to be, therefore make your incision lower. And then when it rises, it's going to be in the spot. We really don't do that anymore, because now we manipulate the fold a lot more. And the other thing is, those scars didn't look very good because you're making the incision on the upper abdominal skin, which is thicker and does not scar as well as the breast skin in the breast crease. Yolanda, I'm going to be talking about different implant profiles, so that'll answer that question about the boost and then getting a gorged look. Yeah, so I did talk, Semaine Johnson, I did talk about nipple sensation. Most of the time you do have it after having a breast augmentation, although sometimes you can lose sensation in a breast. So it's important to understand that. Most likely not going to happen, but it can happen. Okay, Sweet Marley, we're taking care of the incision. I covered that earlier. It's very basic. I have you in our sterile bra, the OG bra to begin with. You put a new one on every 5 days. That's like a dressing. And then you just leave the steri-strip in place that's on the incision itself. And you leave that steri-strip on as long as it'll stay on. And you just wash your body with soap and water like you normally do. That's it. That's all you have to do in terms of the incision. And then at 3 weeks, you're going to start scar care. All right, let me take a couple more. And then we're going to go to, can you scroll down here? Leanne's saying hi. Hey, Leanne. It's a very important question. It's a very good question. When can somebody lay fully on your stomach with implants? Jane, you can lay on your stomach right away, day one of surgery. And I know that's not what everyone tells you, but that's what I recommend. I didn't invent that. That came from surgeons passed away now. He's at University of Texas Southwestern, and very good surgeon. And he sort of started that years ago, and it made sense to me, because I think I want patients to get sleep. There's some patients that are just tummy sleepers, and so I've never had a problem with it, and I think it's very good. Okay, we're getting Sophia Garza. We're going to be doing a live on breast reduction tomorrow. Tonight is breast augmentation. Tomorrow's lift, reduction, exchange, tuberous breasts, a bunch of things. Tonight I wanted to get through all of this recovery stuff and what your mom has, and we're going to go on. We're going to talk more specific now about breast augmentation, and then tomorrow we're going to be doing all the other stuff. Okay, so I'm going to get back to it, and we're going to take advice your mom may have. Advice your mom may have for $500. Okay, and so her quotes are in white. You have to change your implants every 10 years. And I'm gonna rattle through some of these pretty quick. Not true. You don't have to change your implants every 10 years. If you like your breasts at 10 months, they're soft, you like the size, they're not droopy, they're good, everything's fine, you don't do anything, you don't have to have surgery. It's not like a pair of tires. You don't have to change them every 20,000 miles or whatever you do. You don't. Your implants can break. Well, your mom is correct. They can break. If you have a saline implant and it breaks, it just leaks out the saline and your body absorbs it. You wake up in the morning and one of your breasts is flat. It's not an emergency. Nothing bad will happen to you. You could be like that for the rest of your life, and nothing's going to come of it. But most people don't want to have one flat breast, so it would be a reason to call your surgeon. But again, you don't need to wake them up at 3 in the morning. You just need to contact the office and arrange to be seen. It's not an emergency. If you have a silicone implant, then you're most likely not going to know that your implant is ruptured unless you get a CT scan or an MRI for some other reason. So you've got some bad pneumonia, or you've got some back pain or whatever, and you get a CT scan or MRI for those reasons, and then the radiologist says, oh, by the way, your right implant is ruptured. Again, it's not an emergency. Follow up with your plastic surgeon and talk about that. Most likely you won't even have to do anything at all, because when here we're talking about silicone implants, you can have what's called an intracapsular rupture or an extracapsular rupture. So remember, there's two capsules now we're talking about. There's the capsule of the implant. This is the implant capsule here, filled with our silicone, which looks like it's going to run all over the place if you open it up. It really won't. It's highly cohesive. Where am I put in here? Yeah, everything. It's highly cohesive, so it doesn't just leak everywhere. But you have a capsule of the implant. So you can actually have a capsule, you can have a rupture of the implant inside. It's an internal fracture. It's why when we're putting in the implants, we're very careful as to how we put them in, because too much pressure, you can actually fracture the silicone. If that appears on an MRI, there's nothing to do about it. It's not doing anything. You most likely can't even tell that you have any issue with you won't be able to tell you have any issue with your breast. But that's an intracapsular. If you have an extracapsular rupture, what that means is that this capsule of the implant itself broke. Now, again, this looks like it would just pour all over the place and leak. but it doesn't. It's very cohesive. It's like a very, very sticky, more solid kind of jello. So it just stays where it is. You have a little tear, disruption in the capsule here, and your body has already surrounded the implant with another capsule. So we don't recommend changing implants or doing anything if you see that. If you have a rupture of the capsule that your body puts on, and now the implant silicone, this is usually with older implants, that is leaking out, that's where we usually recommend changing the implant. And that you usually will see. You won't need an MRI or CT to discover it. You'll usually feel something or may even see a little change in your breast at that point. But regardless, yes, implants can break. These have very good rupture rates in terms of the long term. They can happen. They're not harmful. Most likely don't need to do anything about it, but certainly talk to your plastic surgeon and see what they recommend. But if somebody comes into me with an incidental, meaning they went to have a CAT scan for problem A and they found out, oh, you have a rupture of your silicone implant internally, we don't do anything. There's nothing that needs to be done. Remember, we're on advice your mom may have. Your implants will cause cancer. So no, in fact, it's the opposite in that women, just listen to me. In fact, women with breast implants, that should not be breast cancer, women with breast implants have been found to have a lower incidence of breast cancer than women without breast implants. So I'm just going to repeat that. So I'm talking about breast cancer here. So your ductal carcinoma, your lobular carcinoma, in situ, all these types of things. So what we consider as breast cancer, if you have an implant, you will be less likely to develop breast cancer than someone who does not have an implant. It's exactly the opposite of what your mom has told you. Now, why is that? There is a capsule that surrounds the implant we've talked about. There's a capsule that your body makes. And if you kind of think of that capsule as like a little army or little soldiers that are all stationed around, they are patrolling and they're going to eliminate any cells, breast cells, that are thinking of becoming malignant. So it's a cell, it's like, oh, I may become cancerous here. Those little soldiers that are part of your capsule surveillance will go and kill those cells. So that's our thinking. We don't know for certain whether that little model that I talked about with the soldiers is 100% true or not. That's what the data is kind of leading to. But we do know for sure 100%, because we've seen it in thousands of women that are studied. Women with implants have lower risk of developing breast cancer than women who don't have implants. Now, it's important to know that there is a cancer that is associated with having a breast implant. It's something called ALCL, which is anaplastic large cell lymphoma. It's not a particularly aggressive cancer. This is not something that happens particularly common, but it is not associated with all of the implants that are being used today for breast augmentation. We use smooth implants. So this surface here is smooth. And the implants that have been linked to ALCL are textured implants. So they've got a material that's either been stamped or sprayed on top of the implant, and it's usually the one that's sprayed has been the implant manufacturer, that they cause them to take the implants off the market. So those textured implants are the ones that are the troublemakers, and the smooth implants have not been associated with any ALCL. And the implants that I've used, except breast reconstruction, I haven't done that for a long time, but when I did use breast reconstruction for a while, we were using textured implants. But here we're talking about smooth implants. You should get a bigger sized implant. So the old thinking like, hey, everyone wants to have bigger implants, so just get a bigger implant to begin with. And I understand the logic, but it's not really correct, because let's say you had a 400cc implant, then it may be in a year or two somebody asks you, would you like a bigger implant? You'd probably be like, yeah, I would. If you had started with a 350 implant, you'd probably say the same thing. If you start with a 425 implant, you'd probably say the same thing. That's just the nature of having a breast augmentation. Patients will typically go through a phase where, like, ooh, these are a little bit bigger than I thought, to, oh, these are nice, to, oh, I wish they were bigger. That's normal. You can't really just put a bigger implant in anticipating that, because you're not really getting yourself out of that situation. What I think, and this is going to get into some of the size and we're going to talk about, is it's best to get the right implant size that fits your breast. So the most frequently patients will tell me, I want an implant that fits my body. The reality is you're going to get an implant that fits your breast, because it doesn't, everyone has different breast size, and not every single person that's tall has a wide breast, and not every person that's short has a narrow breast. Therefore, the breast and the body, everything lines up. So the best look you're going to get to your breast is if we can do a hand in glove fit where we're fitting the implant to your breast. And so I usually personally put in an implant that just fills the pocket, and I think that's how you get the maximum, the sort of the best your breast can look, by completely filling up the pocket that I've created. So I don't really buy this kind of get a bigger implant, because later you're going to want it to be bigger. And the other thing is that shape is more important than the volume, because you can have a nice full breast, people would consider a big breast, and it can look really pretty. But if you're like, well, I really just want a bigger breast, you can reach the point where you start to change from a nice, pretty, good-looking breast to just a big breast. And if you look at most women that have 700, 800cc implants, they are not good-looking breasts. I'm not saying all of them, but I'm saying in general, if you get somebody that has a 800cc implant, which is the largest implant usually that the standard manufacturers make, you end up with just a big breast, and volume is the most important thing. Now, somebody may want that. They may want volume over shape, but I think for most patients, it has to be the shape. You have to have a good-looking breast, and that also is one of the reasons why you can't just like your breast but then want it to be bigger and get the same breast but just bigger. You can cross a threshold where you start to decrease on the beautiness of it and just get a big breast. So I think that for me, shape is the most important thing. I'm not even that concerned with what the final number is. I'm more concerned with how the breast looks. I mean, you're not going to see somebody and say, oh, that's this number, or that's this number. You may think you can do that, but you really can't. And so the shape is really the most important thing. And the other thing is, you can't just willy-nilly put any sized implant in any patient, because there's so much variability with a patient's tissue, with their chest, the ligaments of the breast, the laxity, the distensibility, whether they've been pregnant, whether they've breastfed, whether they've lost weight, how old they are. There's a lot of factors that go into all of these things on your breast tissue. So you can't just necessarily grab any implant size that you like. And we'll talk about that again in a moment. Advice from your mom: get saline implants. They're safer than silicone. Absolutely not true. They're both safe. An urban myth is incorrect that the breast implants may delay a diagnosis of breast cancer. That's not true either. So a saline implant is not safer than a silicone implant. Both of them are safe, and both of them are equivalent in terms of safety. There's obviously differences, which we'll talk about. And I think one of the questions that was asked earlier was, can I get get an extra high profile implant? Because that'll really give you the wow factor. I would not get an extra high. I like high profile. I tend to use a lot of high profile. I like the look. I like the cleavage. I like the fullness. I like the roundness. I like how that looks. I don't use it for every patient, but I do tend to move towards a high profile look. People get confused with the term high profile, and they think that a high profile means it's going high here. It's not. High profile is coming out from the chest. So, can you see this implant on the ground? No. Let me just put the overhead on. I'll just draw this for a second here. So, what the profile is talking about is this direction from your chest. So, how much of the breast the implant is coming out off of your chest wall. So this would be higher and this would be lower. And so that's what the profile is. But they also make an extra high profile one, which really has a dramatic amount of projection from the chest wall. And that's that extra high profile or boost or whatever the manufacturers are calling it. Everyone's different. This implant, it was originally designed for use in women who've had breast cancer. So they've had their breast removed. They don't have any breast tissue. They don't have any fat. And you need as much projection as you can get to make up for that. Because remember, when we're doing a breast augmentation, you have your breast. We're just augmenting. We're helping that breast. We're making it have more projection. When you've had breast cancer, you don't have any breast. You need as much projection as you can. But I find that using these extra high profile implants tend to look weird. I think it's an unusual look, and I don't like it. So I don't use those types of implants. But I've definitely heard mothers tell daughter, I've been there, and I think it's bad advice. You will get stretch marks if you get implants. It's possible, but it's not very common. I mean, I can say I've probably only seen it a handful of times, and that's over fairly long period of time with a lot of patients now. If you've had stretch marks before, you're going to have them after. They're not going to change, but it's not very common at all to develop a stretch mark from a breast implant. Breast implants are risky. No, that's not true. It's an incredibly safe operation. It's a short operation, and we're not entering into any body cavity, simply working on the breast. And the typical risk that we've been talking about tonight a little bit are bleeding and infection. Those are rare, less than 1% chance. And we're not working around any large blood vessels. So it's a safe operation, and the implants are safe for your body. The most common complication following breast augmentation, and that's what I was mentioning, was riding in the elevator, is capsular contracture. That's the most common cause for reoperation after breast augmentation, is a capsular contracture. That is not harmful to you either, although it would, if you wanted to correct the capsular contracture, require a second operation. Okay, I'm going to skip over that. You can't breastfeed with breast implants. That is not true either. Your breast is still capable of producing milk. Your breast really doesn't know whether there's an implant there or not. Your breast is a gland that responds to the hormones to make the milk. Whether it's under the muscle or under the gland doesn't make a difference. You can still breastfeed. You have to get your breast implants under the muscle. Well, that's not true. A lot of implants today actually get placed behind the gland, or another place is actually called subfascial, which I'm not going to get into the real details of that because it's very close for all intents and purposes. It's technically different when you're doing the operation, and there are some benefits to being in that subfascial plane. but it's just considered as a subglandular, meaning under the gland, and we're going to talk about that in a moment, location. But you don't have to have the implants put under your muscle. There's no rule saying that you do. And a lot of patients today, a lot of breast reconstruction patients even, are having their implants placed on top of the muscle. You can't get a mammogram with implants. That's not true either. You can get a mammogram. Sometimes it may require a different look, or they may take additional views if the implant is obstructing anything in the mammogram, but it's not going to change your screening. You're not going to have a breast implant and then be like, oh yeah, you got breast cancer because we just couldn't see it. That's not the case. If they needed to do an ultrasound or MRI or other x-ray imaging as they normally do during a mammogram, they'll do all that so that they visualize your entire breast. So implants will not interfere with your breast screening. What about your mom says, oh, the new fat grafting is better than an implant? That's not true either. Fat grafting, well, number one, it's not new. But, you know, moms can sometimes be a little bit late to the game. But fat grafting has been around a very long time. And it's great. And I've personally done a lot of fat grafting to the breast. And I did that a lot when I did breast reconstruction. But I do it now as well with a breast implant. So I think fat grafting is wonderful. And it can help to, you know, augment the tissue around so that you're not seeing just a round implant on somebody that doesn't have very much tissue. We can build up a little bit of fat there. It can soften the transition points. It can decrease rippling. There's a lot of benefits to a composite augmentation where we use a breast implant with fat. So it's great. It's fantastic. But using just fat alone for breast augmentation, my opinion, it's no bueno. I really don't like it. I don't think it gives you a good look, and I know patients want it, but I think you're just the implant gives such a consistent, reproducible, safe, beautiful result that it's hard to replace that. You can add fat to it, but I think fat substituting is not a good idea. Okay. That's all on the recovery and what your mom says. So now I want to talk about breast augmentation. So we've already hit, what, are you guys asleep over there? I put one to sleep. Okay, so we do have a bit more to get through still. I want to go through it and talk about these things, and because I think it's important. So keep in mind that the whole presenting on social media with nipples and areola can be problematic, so I've had to blur a lot of things. But let's go and talk about who is a good candidate for a breast augmentation. Remember, if you stick around, you'll get this PDF, which is good information, 10 things how to prevent capsular contracture. And remember to follow and hit the subscribe button. I never say that. Look at me now. I'm like a real YouTuber out here. Okay, let's get down to business. Who's a good candidate for breast augmentation? I've grouped these patients into 3 rows. They're all different, but they all belong in their row. So just give you a moment just to take a look. Don't look at each individual one. Just kind of peruse through the row and be like, oh, okay, I see row 1. Row 2 is a little different. Ooh, row 3 looks like they need some help. So if you look here at row 1, these patients have no volume, they have no droop, and they have no real significant cleavage, and they have a normal width to their breast. These patients are good candidates for breast augmentation. These lower 2 rows, they need a lift in addition to an implant. And the second row they can probably get away with a smaller lift with a concentric. Somebody asked me earlier, can I do a lift around the nipple? That's what's called a concentric. It's a smaller lift. And the less droop you have, the more likely you are to get a concentric. And the patients in the bottom row have a lot of droop, and therefore they need a full lift. Those are things we're going to be talking about tomorrow. So let's look here at our good candidates, that first row. It's a very popular operation. 5% of women in the United States have breast implants. Usually for patients that all the typical things that we see, there's no volume, projection, cleavage, the breast can be emptied out having children. Sometimes people can have a lot of asymmetry. So we talked a lot about asymmetry before, but sometimes there is a lot of asymmetry that does need correcting. It doesn't need it, but if you want it, you know what I mean. That's a reason for operating. Sometimes there could be a congenital problem, like tuberous breast deformity, which we'll talk about tomorrow, or droop. So those are sort of all the reasons you'd get an implant. Silicone versus saline, I'm not going to spend a lot of time on this. They're both safe. Silicone implants are better than saline implants. I have no problem saying that. It's important to know that silicone equals gel or silicone gel. They're all the same term. So if you're asking for gel implant, it's a silicone. If you're asking for silicone implant, it's a gel. Sometimes we call it silicone gel. All those terms are used interchangeably. The implants that I use are highly cohesive implants, and those are the gummy bear implants. And a lot of implants today are highly cohesive and are referred to as the gummy bears. That's all I use are gummy bears. I do saline. It's just not very common. It's the same operation. It's just putting a different implant in. But 99% of the time, I'm using gummy bears. And about 90% of all surgeons in the country are using some form of silicone. I think the silicone's better, as I mentioned. I won't go through some of these reasons so we can get to some of these points. Rippling is one of the downsides to having a saline implant. It may not show as well to you, I'm not sure, but if you look at in where her cleavage is, you can see a little bit of scalloping or rippling there, and that can happen. It's more likely to happen with a saline implant than it is with the silicone implants. Another benefit to having a silicone over a saline implant. If you want a saline implant, I'm happy to put a saline implant in. It's just I don't think there's any benefit to it. It is a decreased cost, but I don't think there's any benefit, and I think sometimes people are concerned about a silicone implant and that's why they choose a saline. They don't need to. If they want to, that's fine. I have no problem with that. But I do say that, you're a little bit higher risk of developing rippling because of it's higher chances with saline. Okay, incision location. There are 4 potential places you can have an incision. One is through your belly button. That's not even worth talking about. It. That's not a great operation. And then the other 3 locations are armpit, around the areola, or underneath, around the areola or underneath the fold. I only perform the ones in the fold for all of these reasons. Number one, I'm not making an incision on your breast. It's well concealed underneath the breast. And there's just lower risk of everything. Low risk of bleeding, infection. There's lower risk of implant malposition. We don't have to go through, if you go around the areola, you have to go through the breast tissue to get to where you want to put the implant under the muscle or under the gland. And I just don't see the point of contaminating things by cutting through your breast. And there's less risk of capsular contracture if we go underneath. So for all of those reasons, I make the incision underneath the breast. Where do I put the implant? Well, everyone's always talking about under the muscle, over the muscle. Well, what muscle are we talking about? The muscle we're talking about is a pectoralis major muscle. That's the largest muscle on your chest. That's the strongest muscle on your chest. That's your pecs. That's what the bodybuilders build up. And so it's we're going either under the muscle or we're going on top of the muscle. And those are the 2 locations. They're both good locations for an implant for different patients. So some patients can be a candidate for one and not a candidate for other. Sometimes patients can be candidate for both. So, excuse me. So this is a short video here. And I'm going to just leave the sound down and just kind of narrate a little bit for you. And what I'm showing here is that I'm going to be placing this patient's breast implant underneath her muscle. So this is a submuscular implant. And where I've drawn that dotted line there that goes right across the little sticker, that's actually where the muscle is going to get released to, because the muscle itself attaches right where you have that crease, where you have your fold. The pectoralis muscle attaches there. The problem is, if we didn't release this muscle, free it up, and let it come up, it would stay down and the implant would be up here. So we have to actually release the muscle to let the implant come down so you get a nice look to your breast. So even if an implant is considered underneath the muscle, it's not actually totally under the muscle. It's only under the muscle, really more in the middle and the central part of the breast, because we've released the muscle underneath and let that come up. And there is no muscle from this point over. So an implant that is under the muscle is also partially under the gland. That's the reality of it. And so what I've shown here is that dotted area where I've got the little hash marks. That's where there's no muscle there. So all of that area is free. So you see in this little picture here, see how that muscle at the bottom, the red one there, it's been cut to allow the implant to come down. If you didn't have that, the implant would stay high because the muscle would keep it up high. So we have to release that because we want the implant to be positioned correctly underneath the breast. We don't want the implant all up here. We want the implant positioned nicely underneath the breast. So these are the two locations that I talked about. The one on the left, the subglandular, it's really subfascial, but again, I don't want to get into all that just gets too complicated. Just consider it on top of the muscle or under the muscle. So on the left here, the subglandular, that's sitting on top of the pectoralis major muscle. The one on the other side goes underneath the muscle, and we've released the muscle, so it's not totally under the muscle, but a lot of it's under the muscle. So those are the two locations where you can have where you can place the implant. The general rule of thumb, again, these things are a little bit more complicated, but I'm not trying to make you a surgeon. I just want you to have some idea as to what's going on so that you're educated. There's, generally speaking, if you're going to put the implant underneath the gland, right under the breast, you need to have enough tissue that's there so that you don't just see this implant and you don't feel this implant right there. You have to have enough tissue. If you really don't have very much tissue, you just have to go underneath the muscle because you need the muscle to act as extra tissue. If you have a lot of tissue to your breast, you have some breast volume, have some fat that's there, then we can put the implant underneath the gland. And that's where I would prefer to put it if you have enough tissue, because you don't get the problems with animation that I mentioned when you put it under the muscle and the breast implant's moving. It's a much easier recovery. You don't have all the pressure. And it looks really pretty because it's where your breast is. And if we're trying to augment the breast, your breast is not under the muscle, so we're just augmenting the gland. So it's a good operation. I do it. I still more commonly put it under the muscle because more patients are candidates for that. But if I can put it under the gland, then I put it in that position. Okay, let's talk about, so I told you where we use the incision, where the implant goes. Here's one of the complications. This is what I've mentioned to you when I was riding in the elevator, is something called capsular contracture. So here's somebody that she's had her implants for a very long time. You can see in her left breast, it's balled up, and it looks different than her other breast. So that is a capsular contracture, and it was bothering her because it became painful. Most of the time, capsular contractures are not painful, but they can become painful, and it can be a reason why patients want them removed. So here's a study that was just published a few years ago by Dr. Hidalgo, really well respected breast surgeon, both reconstruction and cosmetic. And he did a study looking at capsular contracture, and based on all of the data came up with this algorithm or treatment plan. And I'll just run you through that. It's not very complicated, but it says here at the very top, if you're looking in the gray, it says laterality of capsular contracture. That just means, is it unilateral, meaning it's on one side, or it's bilateral, meaning it's on both sides. Typically it is on one side, but you certainly can have it on both sides. It is possible. And if it's, let's just say, if it's on one side, then what we will typically do, we'll go in, we'll remove the implant, we'll remove the capsule, we put a new implant in, we start again. If that works, which it does about 70% of the time, then we're fine. You don't have to do anything else. If you've gone through that, you've had a capsular contracture, you had the implant removed, had the capsule removed, and then you developed another capsular contracture in that breast, that's when we go to something called ADM, and I'm gonna show you a picture here in a moment. So if you have a repeat capsule, you go to ADM. You have to go to the ATM too, I assume. You go to ADM. If you have implants in both sides, you would immediately go to the ADM. You don't have to do this, but this is what the data suggests to do, and this is the treatment protocol that I talk to patients about. If somebody comes in with bilateral capsular contractures, I'm like, you should do ADM. It's going to be the best for you. And that almost decreases your chance to zero of ever having a capsular contracture again. So why don't we use ADM just in everyone? Because the rate of capsular contracture is small. So you'd be treating 97, 98% of the people would get ADM for no reason. And it adds costs. And every time we do something else, there are other risks and complications to it. So we don't use it for everyone because most people don't have a problem. It's only when you have a problem, either repeat capsular contracture or bilateral capsular contractures, that we use the ADM. This is ADM. This is an old slide of mine. So it shows an anatomical implant, which was it looks like a breast rather than being smooth and round, which ours are smooth and round. They get into a natural shape when they're in the body, but for a while they were making these anatomical implants that I used for reconstruction. So anyway, the point of this is to show you the ADM. ADM stands for acellular dermal matrix, and the trade names are either alloderm or stratus. And what that is that's dermis. So the thick layer of the skin that's been removed from either a person or a porcine, which is a fancy way of saying pig. So it's dermis, either taken from a human or a pig, that has then been specially proprietary treated to remove all of the cells. And it acts as a structural network. And what the studies have shown is that if you wrap an implant in that ADM, it will prevent you from developing a repeat capsular contracture. And so it's very effective treatment. And I do it because it's, for those patients, they gain a huge risk reduction of developing another capsular contracture. Okay, I'm going to talk about somastia only because I want to show you this cool video. Somastia is just when you have this. So she had implants. I did not do them, but the pocket has been joined. And you can get into this situation where the surgeon will over dissect the pocket, or you're using implants that are very big for the patient and there's not a lot of room, and they develop this plane, they do it. I'll just play it. Let me go back. Play it one more time. So what you'll see is I'm squishing her implants from the side, and they meet in the middle. They get this sometimes called bread loafing appearance. And so what I did during this operation, we removed her implants, and I repaired the symastia. Usually the surgeon wants to go to a smaller implant because the problem is that this is all lifting up, and so we want a smaller implant to put less pressure. But usually patients want to go bigger. So I try to have the patient stay the same size, or if we do go bigger, I go a tiny bit bigger. But here you can see her after. This is quite a few years ago. And I'm squeezing pressure on her breast implant, but it's not moving anymore. It's not connected. So that centerpiece has removed. That is one of the risks, and I've seen, to be honest with you, I've seen more symastia since I moved to Miami than I ever did before. And she's not somebody who has extremely large breast implants, but in Miami there's kind of a push to get bigger and bigger implants, and I've seen and repaired symastia quite a few times because they unites, and I think it's because the implants are too big. Okay, let's talk about implant size. I'm not going to bore you to death, but just understand that over the past however many 15, 20 years, I've used and seen every single different thing, including software and imaging, and I'm right back to where I started in terms of picking the implant size. And I'm very focused on picking an implant that fits the breast and is a hand and glove fit, so you get a beautiful shape to your breast. And so what I do is I create the pocket. Yeah, it's all about the shape. We get the message. And so I create the pocket to the boundaries of what's going to be the breast, and to get the best cleavage and the best shape and the best projection. Once I create that pocket, I use a sizer, which is a temporary implant. And it basically, can you see this? How's that? Oh, can you see it on the white? Should I do this? How about that? You can or you cannot?
You cannot.
Okay, can we do something to see it?
Just put it on the computer.
It is on the computer. Good?
Yep.
Okay. So what I do is I use a size. This is a sizer, obviously not one we're going to use, but I just inflate it with air, and I'll show you a little video. Good? And so I inflate it with air. Once I've created the pocket, and then this I just put that one back, and this will blow up, and it goes through and shows you what the pocket is going to look like. And it helps me to make sure that I've defined the pocket correctly, and it guides me in how I'm going to select an implant. And it allows me, I think, to get the best shape that I can get from a breast augmentation and get somebody a nice full, somebody mentioned engorged. I like that sort of full engorged look. So it depends on your breast size, it depends on the width, it depends on the height, it depends on a whole bunch of variables. But after I've taken all of that into consideration, oop, I can't show that one, sorry. There's nipples in that one. But anyway, that video is just showing you how inflating the breast, and you can establish that. Once I do that, that's when I pick the size of the implant, and that's when I place the implant. So I can give you an idea what the size is going to be based on experience and measurements, but I know there's a huge movement that has gone on in plastic surgery over the last quite a few years to do all these measurements, make everything perfect, and then use that implant, and that's it. Don't change anything. I went through all that, and I did it, and I just found that I was happier when I had a little bit more artistic control myself when it was at the end and I was making that final decision. And that's how I get, I think, a full, pretty shape to the breast. That's my technique. I'll just show you a couple before and afters. Again, it's kind of with all the nipple covering, it's a little problematic. But up top is her befores, and at the bottom her afters. You can see all the things we talk about. It's a beautiful shape. She's got, and you can see she actually has stretch marks before and after. You can see. You can see the nice cleavage. Then it's not one of these implants where it's up here around your neck. The reason they do that is because the implants are so big, they can't fill out the breast. They only can go north. Here's another example of somebody with a before and after. Same kind of concept. We're treating somebody that really looks fairly masculine in that upper before photo, the one from the front. And then afterwards, she looks much softer and a much more feminine appearance to the chest, which I think is pretty. We talked about one of the things your mother may have to say to you. Well, she's probably going to tell you about the implant size to get because she got this one, or the aunt got this one, or her other daughter, whatever. Your implant is totally different than anyone else's implant. You have to get an implant that fits your breast, that fits on your chest. And just because you have a bigger implant doesn't mean you're going to look bigger than somebody that has a smaller implant, because that smaller implant could have a bigger impact on a smaller breast than a larger implant does on a bigger breast. So here's a perfect example. Who has a larger implant? Looks to me like the patient on the left. Well, turns out she has 425, and the patient on the right has a fairly big implant at 600. But they look totally different. So you can't say, oh, I like her breasts with the 425, let me have the 425, because you maybe look better with a 600, or vice versa. You could look better with a smaller implant. The 600 would not fit on the patient on the left that had 425. She would get so much distortion. I would have to open up the pocket beyond the area that's going to give her a pretty breast and just get a large breast that doesn't look pretty. And that doesn't make any sense to me. Okay, because, at the end of the day, you're living with these breasts. These aren't just static images that you take in the plastic surgery office before and after. These are dynamic. You're moving, you're wearing clothes, you're having dinner, you're taking care of your kids, you're working, whatever you're doing. And so it's just important to see how the implants look in the daily life. This is a perfect example. She has nice fullness. She has a bigger breast. She has nice fullness, nice cleavage, nice roundness, good projection. And that's just something, obviously she's comfortable with it. She's wearing a more revealing outfit. You could wear something more conservative, and if you size the implant to fit the breast, you don't have to always look augmented. If you want to look augmented, you want to show your breasts off more, you can wear more revealing clothes that will do that. It gives you a really nice, I think if you go for the hand in glove, match the implant to the breast, it gives you a nice breast, and it gives you a lot of ways to wear your breasts. Okay. Let us talk about cleavage, escote. So with cleavage, I can't tell you the number of times patients have said to me, I don't want my breast to be out here, separado. I don't want my breast separated. I don't want them separated either. But this is a plastic surgical secret. We can't control the position that your breast is on your chest. Some patients have breasts that are more naturally close together, and some patients have breasts that are further apart. So we are beholden to where those breasts are on the patient's body. We can augment them. There's little tricks we do with the pocket and to get cleavage and everything else. But if you have a very widely spaced breast, there's nothing we can do to move that breast. So cleavage is something that is determined, again, there's things we do, but by and large is what your cleavage is. So here she is before and after, before with the purple marks. Now, if you carefully look at the photo on the left with the purple marks, you can see I put like a little dotted dashed line in there indicating where her cleavage is. So she doesn't have a lot of breast tissue there, but I can tell when I manipulate the breast, okay, that's where the cleavage is. So I want to get out to that point because I want to maximize her cleavage. But look at the little difference. So if you look at her breast, I'm talking about her breast, which is her right breast. Remember, this is the opposite side when we're looking at the photo. So if I'm looking at the photo, her left breast that I see is actually her right breast. So on her right breast, and you look at the after photo, it's very round. And if you go back and look at the marks on that right breast, they're very round. But now move your eye over to her left breast. So move your eye over to the right. And you'll see where I had those dashed lines, and as they start to join that solid line under the breast, it's a little flatter, it's a little straighter in that area. Her other breast was rounder. Well, if you look at the after, you can see that there's some of that flatness in that area. You can't just automatically, we can push it to the limit, we can get the maximum that your breast has to offer, but if there's a little area like that, or there's a little, one of your breasts a little off to the side, you're still going to see that after surgery. That's normal asymmetry. Her breasts look nice. They're beautiful, and she's happy, but they're not perfect, and we can't control that. This is really more of what I would consider kind of ideal or perfect cleavage in this patient here. She has, her breasts are about a pen width apart. That's the ideal cleavage that people want. I'm not saying everybody does, but that's kind of the ideal cleavage. I happen to think it's great that not every single person looks like that, and there's variability because of what makes humans human and attractive. But that's the ideal cleavage. Looks great in a bra, looks great naked. But there she is on the top right. Okay, that's her. I just showed you on the bottom right in the after photo. That patient as ideal cleavage. If you look at her before picture, you would look at him like, well, how did that happen? Where did the cleavage from? Oh, he must have just put the No, I didn't put the implant over. I just put the implant where I could and maximize the cleavage that she had. And she had great cleavage, so she ended up with this perfect cleavage. Not everyone has that. There's always differences in the spacing. I can maximize it. I can get you the best cleavage possible for your breast, but I cannot put an implant where there is no breast. Meaning, I can't put an implant in the center of your chest on top of your bone, because if I do that, you're going to develop that symastia where you squish on either side and your boobs are like whoop. So you have to respect the boundaries, the surgical boundaries of the breast. I work hard to get the very best cleavage I have, but the spacing I don't have any control over. Okay, I hope that's clear. Now, let's talk about implant descent. This doesn't really happen as much anymore because we really release the muscle more and the implants come down. But there are patients who you can see that have this very fullness at the top. It's really when you're kind of pushing the boundaries to the highest level, that will settle. And you'll see here, this is a different patient, but you'll see her progression. The interesting thing is she maintains the same degree of self-tanning bed the entire time. So her skin tone never changes. But I know her, so I can say that. But you can see how things look differently over time, and it only makes sense. You're always going to get a little bit of softening, a little bit of settling. See how in that middle photo she had a little bit more shininess to the skin? All of that goes away as the implants settle into position. So In the old days, our implants really started high and they really had to go down a long way. Sometimes they didn't drop. We would have patients wearing bands to push them down. We'd have them doing exercises to get them to come down. We really don't do that anymore. We don't need to do that anymore because we're much better at getting our pocket and releasing more of the muscle if we're going under the muscle or the subglandular position. We don't really need to wait for the implants to drop anymore. But there still is some natural healing time, and it takes a little bit of time before you get your final result. I'll just show you a couple other examples of what we're talking about in terms of just getting a shape, getting something that fits, and getting something that fills cleavage. You can see in her upper photos, she really had very little volume. You can actually see her chest is actually kind of caved in a little bit at the top. And so she has some normal asymmetries that we can see in the after photo. But in general, this is not somebody I would say, she's really wildly asymmetric. Again, fullness, roundness, cleavage, trying to get the very best shape that I can get from that breast. Not everyone gets the same shape because everyone has different looking breasts and different breasts to begin with. Okay, that I think is the end. And I know it's taken, what time is it? 3 in the morning? So, okay, it's 9:30. We're going to, I'm going to take 15 more minutes of questions. And remember, stick around. You will receive the PDF of how to top 10 ways to prevent capsular contracture. Let me take a few questions, and then we will call it a night. If you do have any other questions, leave them in the comments. I'm actually kind of like a little bit obsessive about going through comments because the whole point of this is to educate. And I want patients, when you go to have your breast augmentation consultation, hopefully now, if you didn't see all of it, you can watch it again. If you go in there and you don't have all the preconceived myths and incorrect information and things your mother says, obviously I'm just being facetious about that, but a lot of things your friends or whatever, and you have more knowledge, that's the whole purpose of this. And it will make your consultation more valuable because you can focus on the questions that you want to ask. But if we don't get through a question that you have here, leave it in a comment. You can also email me. My email address is very easy. It's just Dr. William Miami. It's the same as my channel name at iCloud.com. You're welcome to email me a question and I'll answer that for you. And if you have a question, leave it in the comments and I'll answer it for you. Nurse Fancy is saying, do lifts last or are you better off just getting an implant? That is a question that we're going to answer tomorrow because we're going to talk about implants and lifts tomorrow and just lifts, and I'll be answering kind of that question tomorrow. I really have to give you some more diagrams and show you to be able to do that. Lady Donna, will the breast implants look the same after breastfeeding? They may or they may not. It's impossible to tell. Some women's breasts change a lot after breastfeeding. Some women's breasts change nothing. I mean, it's really surprising. So it doesn't really depend if you have an implant or not what's going to happen. It's just what your genes and your tissue and what's going to happen to your breast after you breastfeed. So you may be fine. You may have a change in your breast. It's really hard to say. It's individual. Do I use smaller implants if I'm fat grafting? Not really. The fat grafting, if you look at the volume that we put in when we do fat grafting, it may be 100 cc's, 125 cc's. It depends. Everyone's different. So maybe 200 cc's, but that would be unusual. It's more like 100, and that's spread really around the breast to feather and smooth, and just so we're trying not to get it so that we have, here's the breast and here's your chest. We're trying to fill that in, particularly in the upper pole and the cleavage, just to soften it. So I create my pocket, I put the same implant in, and then I use the fat not so much for driving the volume, although it will give you a little bit more volume, is I'm using it more for shape. Xenia Damien, if you have saline implants 20 years ago, do you recommend changing them out? If you have no problems with your breast, you don't, and you have a smooth implant wall, then you don't have to change your breast implants out. Doesn't matter if it's 10 years, 20 years, 30 years. Okay, Gabriella Mexia says, when you have capsular contracture and your implants are changed, where do you open and insert a new one's house a scar? That depends. If you've just had a straight breast augmentation and you developed a capsular contracture and you, can I close this? Yeah. And you don't need to, what am I saying? Oh, so if you just had a straight breast augmentation, everything looks fine, and we're simply going in, removing the capsule and putting a new implant in, you don't need to have a new incision. We can reuse your incision. If you've had your incision around the areola, then I usually will reuse that incision. If you had the incision underneath, I'll reuse the underneath one. And you may, that's maybe all we do. Just open the incision, take the capsule out, put a new implant in, we're done. If you need a lift, if you want to go a lot bigger, if you want to go a lot smaller, there may be other scars that we need to do to accommodate that. But if it's just a straight up, everything's good with your breast except you have a capsule, I just reuse the same incision. Lady Donna, what about fat transfer? Not sure if I want actual implants. Would you be able to do that? And a tummy tuck in the same procedure. So I don't do breast augmentation with just fat. I will use an implant and fat, but I always use an implant if I'm doing a breast augmentation. So I don't do purely fat breast augmentations. So the answer to that would be no. When taking a shower after surgery, do I use Hibiclens? Hannah, you don't. You can just wash with regular soap and water. At that point, you don't really need to. The incision's been made, and we've already dealt with all that bacteria. So now you just go back to normal, just washing with regular soap and water. You're going to have a sterile Steri-Strip on your incision, and you're also wearing the sterile OG bra. Can you breastfeed with implants? Yes. Dominique Duncan, can you get a BBL in the breast? Yes, you can. I call that the mini mummy makeover. I love doing that operation because it's amazing. You're removing the fat, you're enhancing the shape of the butt, the hips, the legs. So you're getting a fuller, rounder, prettier butt, smaller waist, and then you get breasts to kind of match. It's wonderful. You can recover from that, a BBL and the breast augmentation at the same time, because you can sleep on your tummy after having a breast augmentation. Can areola size be increased with an augmentation? Shireen T. That's a good question. The answer to that is yes. Is it really significant, or does it? Have I really had anybody complain about it? No. But if you carefully look at, you have to realize that we look at our before and after photos as surgeons as our own quality control and learning and everything else. Now, do I look at every one of my breast augmentations before and after now at this stage of my career? No. But 15 years ago, yes, all the time, because you're always trying to get to where you want to go. So sometimes you'll notice it, but it's really nothing significant. So I don't think it's anything to worry about it. Sweet Marley says, does the after surgery bra have to be tight? So the OG bra is, it's super, can you give me one of the OG bras? It's very flexible, and it's it's got a lot of 4 Velcro adapters. So it's meant to be snug, but never do we want any of these things, whether it's a faja or a bra, to be just too tight. You don't want to ratchet it down. Just snug but comfortable is what I usually say. How to prevent saggy implants after pregnancy? Jane, you can't. Your body's going to do what it's going to do. Can you leave Chanel Smith is saying, can you leave your nipple ring in when getting breast augmentation? Absolutely not. We can't clean and sterilize around that, and that would lead to an infection. So no. What I usually recommend patients with nipple piercings is remove your remove your piercing, replace it with a plastic one. Come in on your day of surgery. We can remove the plastic one and clean everything properly, and then you wash and prepare it all, replace the plastic. We do the same thing, and then you can go back. But definitely cannot operate if you have anything in your breast piercings. So Michelle Tobra, it may or may not be the case. I would see your surgeon and ask, but you should be able to tell the difference, not you as a patient, but your surgeon will be able to tell the difference between an implant that just didn't drop. I mean, that's really uncommon now. I mean, I can't even, it's been years since I've had an implant that didn't drop because we've been releasing the muscle more. But you should be able to tell the difference, not you, but your surgeon should be able to tell the difference between an implant that never dropped and an implant that is a capsular contracture. They feel different, they look different. So I would just see your surgeon about that. Tina Cole, how do patients determine how much asymmetry is normal after they fully healed? That's an interesting question. I've never really thought about it in that regard. If you're really concerned about asymmetry, then I would just sit down with your surgeon and say, it's best not to go into your surgeon and say, hey, this is probably, just do it in a relaxed manner and say, listen, I've noticed my breasts are not symmetrical. I thought they would be more symmetrical. Is there something that we can do to make them more symmetrical, or is this the way you think they're going to be? And then you'll go through and you can look at the before photo with your after photo. It's really good to look at your before and your after on the same screen, just like I was doing with the before and afters. And then you're looking at it almost like a third party. You're a third party observer, and you say, okay, let's look. Oh yeah, I had that asymmetry here. Okay, all right, that's the problem. I see it there. Okay, nothing we can do. I got it. Or you might say, wow, I didn't really have that. I wondered, is that something that could have changed? And maybe that would be, and that will start a discussion. And then you can determine with your surgeon, hey, is this something that we should do something about? Or say symmetric, move on, get on, and carry on with your life. Can you sleep on your stomach? You have breath lift with implants? No. You cannot do that. I'm going to talk about that tomorrow, but you cannot sleep on your stomach if you've had a breast reduction, breast lift, or breast lift with implants. You can sleep on your stomach after having a BBL. That's why I'll do a BBL at the same time as a breast aug, but I won't do a BBL at the same time of a breast lift reduction or breast lift with implants. Can I have plastic nose piercing and belly ring for surgery? Hannah, yeah, sure, that's not an issue as long as nothing's in your breast. And the plastic is safe because it's not going to conduct any electricity, although I don't know if that's really true, but that's what we've always been told. Leslie, hugging, can you make the area smaller? Excuse me. I can make the area I can make the areola smaller when I do a lift. I can't make the areola smaller at the same time as a breast augmentation just to make the areola smaller, because the only way you can make the areola smaller is when you have enough tissue. When you have enough tissue, it's when you need to do a lift. So if you're doing a lift, you can make the areola smaller, but if you're having a breast augmentation and you don't need a lift, you cannot make the areola smaller. You can make the nipple smaller. That's a different topic, but you can make the nipple smaller, but not the areola. Julie, Rich, can you have breast augmentation after recovery from a breast abscess? You can. I would wait a year personally, but at least 6 months. And I would make sure, I'm assuming if you have a breast abscess, you have some cultures. So I'd make sure your surgeon knows what was the bacteria growing in your abscess, and if there was a cause for it, which probably they don't know the cause. It could be just a little clogged duct. And find out what the sensitivities to the antibiotic, what the sensitivities are for the antibiotics based on that bacteria, because you would want to do things, treat the patient maybe a little bit differently to make sure you're covering those bacteria. Hannah, it's kind of minor. It's not really an issue in terms of stretching or getting bigger. Dominique, do you get massages after implants? No. You do self-touch and generally light massage, but you don't get any formal massages, and you don't need to be doing any aggressive massages. Or maybe I'll this. Okay, hang on. There was some in the bottom, but okay. Well, that's good. I think we've covered a lot of ground. And there was a lot of, there's just a lot of stuff to go through with recovery. But tomorrow night, we're not going to have to go through all that, because the recovery from an AUG and the recovery from a lift is basically the same. So I'm not going to go through all the recovery, and we'll get into, because we have a lot to cover tomorrow, into all the specifics about a lift with implant, reduction, all the things that I've talked about tonight. So please, by all means, subscribe to my channel. My goal is to educate and inform patients, and I love to do that. Please join along in this crusade. Turn on the notifications. You'll get notified about lives, any new videos and shorts that come out. And if you have any questions, please leave it in the comments. Don't forget, we're going to give you this PDF it's going to be on the link in the comments bio, something there. You can find it. It's going to be linked there. And there's actually 2 other PDFs. They're good. There's something that you can read and hang on to before you have your breast surgery. So until tomorrow, I hope everyone has a good night, and thank you very much for watching.